Good morning, everybody. It's great to see so many familiar faces, but it's also great to have a number of people who are joining the event for the first time. So welcome to everybody. Just before we start, I want to hand over to Alana just to remind us of Zoom etiquette for today.
Fabulous, thank you, Steve. So yeah, we're probably all familiar with it by now, but it's kind of a standard at the masterclasses. We'll just go through it in case. So if you hover your mouse in the middle of your screen, a bar should appear at the bottom. On the left-hand side, you'll see there you can mute, unmute yourself and stop and start your video. If we could ask everyone just to stay muted until we invite you to do otherwise, there will be some time for some questions. So it may be that we come to you and ask you to unmute your microphone then. And also we will be recording the session today, so if you would like to be included in the recording, keep your video on. It's great to see everyone's faces, but likewise you can always turn your camera off at any time if you'd like to do so. You can, if you click participants at the bottom, there'll be an option in there to raise your hand. So I'm here as tech support today, along with a couple of colleagues, so I'll keep my eye on that. Raise your hand if you do want to get my attention. Equally, you can also message me directly in the chat box. So when you open up the chat, if you see where it says in the message box to everyone, you can just start typing my name in there and send me a private message if you've got any issues. And as well, do get involved in the chat box. I can see loads of people have been doing today. So if you have any burning questions throughout, like I say, we do have some specific time for questions, but if you just want to put any comments or questions you have in there, then we can try and get round to it in that time as well. If you're having any issues and you would prefer to call me, my number is in the chat, so I'll be here with my phone. Pass that on to any colleagues if you know they're having any issues getting on. And I would say just keep everything else closed, your emails, sign out of them if you are experiencing any difficulties. That should help. But other than that, enjoy the session, and it's lovely to see everyone.
Thanks, Alana. Just a couple of other points. We are recording the event, and the recording and the slides from the event will be available as soon as the event's finished. Also, we're not planning to take a formal break, so please do take tea and coffee or comfort breaks as and when you need them, and we are looking to finish around 12:15. So on behalf of the 6 partners that work together to design and deliver the masterclass series, I'd like to welcome you to today's event. Those 6 partners are MIA, who I work for, the other 5, the Innovation Agency Northwest Coast, Northwest Leadership Academy, Northwest ADAS, Northwest Employers, and Aqua, and we're all delighted to welcome you here today. As we were saying earlier in the chat, this particular event's always been one of the most popular in our calendar, and it must be getting on for 10 years now since Anita and Chris first presented at the event, and I know they look forward to their annual double acts each year. The focus of this event, the annual health check, is to reflect on the previous 12 months and then to look at what the future might hold. Last year was certainly a year unlike any other, and the events that we had to contend with and the impact of the pandemic was devastating for everybody, and everybody's well aware of that, and also the fantastic work that the health and care systems have done in response. At MIA, we've certainly seen firsthand the work that all the NHS organisations that we work with in the NHS have done, and the fabulous impact that has had. And whilst there does seem to be some light at the end of the tunnel, it's important to learn from our experiences, and in particular, the impact of collaborative working that's had, and how that can help to support us in meeting the challenges ahead. In addition to Anita and Chris, it's great to welcome back this year Sally Warren, Director of Policy, King's Fund. So welcome, Sally. But to start with, I'd like to welcome Richard Stubbs. So Richard is the CEO of Yorkshire and Humber HSN, and he's been recognised as one of the most influential BAME leaders in healthcare, in the first Health Service Journal BAME Power List. In his role as CEO, Richard leads on a number of significant projects that help improve health and care services for the future, including the recent Levelling Up Yorkshire and Humber Health as the new well, post COVID-19. This is about importance of leveling up future investment in assets as well as begin living and beyond COVID-19. Richard's passionate about transforming lives through innovation and also leads on the NHS reset work. I'll now hand over to Richard, who's going to open the session and to chair the event. So thank you and welcome, Richard.
Thanks, Steve, and thanks to everyone actually at the Northwest Learning Collaborative for inviting me to speak and to chair this session. It's an absolute pleasure to be here, and I'm really looking forward to hearing from our eminent speakers shortly, as Steve's just outlined. I also recognise I'm a complete newcomer to this, and as everyone's been saying on the chat, you know, many people have been here for 4 years running, so I am very much the new boy here, so looking forward to it. Please do think about your questions as we go, and we will be keeping a close eye on that chat box. And as Steve mentioned, you know, please do share your thoughts on social media as well, and use the hashtag collaborative NW. As Steve said, the theme today is very much about looking back in order to look forward, and each of our speakers will be offering their own perspectives and narrative about the challenges ahead, but always through the lens of how the pandemic will shape our challenges and actually sometimes our opportunities. I'm going to share a few slides with some of my own thoughts about the impact that the pandemic's had on health inequalities in particular, and what lessons we can take into our future work. And then very shortly, I'll be handing over to Sally to kick us off properly. So could I have the next slide, please? Ooh, and the next one. And one more. Thank you. Sounds like I'm taking 2 from the top and five other numbers, please, Rachel. That's great. So it's an obvious thing to start with, but it's still worth saying that you know, the prevalence and the impact of inequalities across the country has been acknowledged for some time, long before the outset of the COVID-19 pandemic. I mean, for example, I mean, Steve mentioned some of the work that we're doing in Yorkshire and Humber on levelling up, but in Yorkshire and Humber, we have the 3rd lowest life expectancy for men and women, 1 year, 10 months lower than the England average, and the 2nd highest levels of obesity in England. And on average in Yorkshire, women live 21 years of their life with ill health. I'm sure everyone on the Zoom today will know about the update to Michael Marmot's report from last year, which very clearly shows how time spent in poor health increases for men and women in the most deprived areas of England, and the north-south health gap has increased the difference in life expectancy between the least and the most deprived. And his point that the health of the population is not just a matter of how well the health service is funded and functions, although that is of course very important, but health is closely linked to the conditions in which people are born, grow, live, work and age, and the inequalities in power, money and resources, the social determinants of health. So to put it simply, it means in order for people to live healthy lives, it's not just about ensuring they have access to healthcare services, it's about ensuring they have the ability to make healthy life choices from childhood, something which is influenced by things such as the area they live and the access to outdoor facilities and their household income and a number of other variables. Next slide, please. So we know that the pandemic has had a significant impact on all parts of the population, understandably, but we also know clearly there's been a disproportionate impact upon specific parts of the population, including those within ethnic minority communities, older people, people in the country's most deprived areas, those who are obese or overweight, and those living with long-term health conditions. So you've got some examples on the slide there in front of you, but just to pick one out, by example, patients from Asian backgrounds are 1.4 times more likely to die compared to those from white backgrounds, and patients from black backgrounds were 1.3 times more likely to die. This disproportionate impact has been largely driven by the inequalities present within society. As I mentioned, inequalities that were completely apparent prior to the pandemic, but have only been exacerbated. And I think importantly for me, COVID-19 has shone a bright light on that prevalence and impact of inequalities within society. And it's really important that this increased understanding and awareness that we have is built upon as we start to recover in a post-COVID-19 or a living with COVID-19 world. Next slide, please. And of course, we also need to reflect on the impact that the pandemic's had on the health and care system and its workforce. Chris will dive into the career. Just have the next slide, please. Chris will dive into this area in a deep way later. Thank you. This time last year, we knew that overnight health systems were transformed. I mean, for my own role in the Academic Health Science Network, my day job is to accelerate the spread and adoption of technology. We saw the adoption of technology at pace and scale that hadn't been previously anticipated. The kind of things that usually takes a health service 10 to 12 years to do were done in a matter of weeks. A couple of examples there, you know, the increase in primary care practice using video consultations and primary care practices again using online triage. There are many, many more examples. Now, not all of those changes, of course, are positive by any means, and we're doing a great deal of work now and have been for the last 12 months to evaluate and understand those changes that have indeed been beneficial, and to understand those changes that do need to be supported, sustained, and continue to be adopted. Next slide, please. But as we stand here, I suppose, in April 2021, it is no less a daunting challenge than it was in April 2020. It's probably just a different challenge. We have an unprecedented backlog of procedures, and we have a workforce that is quite frankly knackered, with many considering leaving the service on top of the huge number of vacancies that we already had this time 12 months ago. Next slide, please. So, and hopefully we'll get into this, I think, in the conversation as we go on, but the only way to tackle the challenges that we're now facing as a health and care system is by working smarter, not necessarily by working harder. It's not just about building more hospitals and employing more staff, fantastic that would be. It's about working in a more innovative way, making more use of technology, a better understanding of the needs of specific communities, and ensuring we design those services that meet those needs. And I think coming back to the point about the inequalities and how the pandemic has shone a light on that, I think it's absolutely crucial that this needs to be done in conjunction with our representative communities, particularly those from marginalised groups. We need to ensure that the services that we design in light of our learnings, our lessons from COVID-19 meet their needs and their factors. There are some huge risks ahead of us if we get this wrong, such as digital exclusion. So, for example, while the rapid rollout of remote consultation in primary care was probably a success, it's caused issues for some parts of the population who don't have access to that required digital technology. While through the necessity due to the pandemic, the work was delivered at pace, how can we learn from that? What should we do differently in a period, a less frantic period, I would suggest? How should those changes to services and the way that we access them be co-designed with representatives from all parts of our populations? The pandemic provides us with a platform to build upon to achieve this. I mean, the right time to do this is therefore now, learning from and building upon the recent progress made throughout the pandemic, and crucially for me, the shift in mindsets. I've spoken and written a deal actually over the last 12 months about how, for me, the most important transformation that happened in the health service over the last 12 months was the cultural shift, rather than anything nuts and bolts that we achieved in terms of the way that we managed to adapt and change pathways, particularly to a more digital function. It was the cultural challenge, I think, and the cultural change that we saw, which allowed the health service to perhaps just deshackle itself from some of the anchors that have stopped us from moving at pace previously. But we perhaps only have a time-limited opportunity to achieve this before people naturally revert to older or traditional habits and working practices. Next slide, please. So this has been our focus at the Academic Health Science Network. And we've produced a lot of work over the last 12 months around what we called Reset. I mean, we did it alongside our colleagues in the NHS Confederation and the Health Foundation particularly. But we were seeking to capture the learnings and the changes in working practices, and as I said, the mindsets that have originated throughout the pandemic, and to evaluate them wherever possible. That's crucial, and to ensure that they are retained or spread further if, and that's a crucial word, if they have the potential to offer value to the future. So the work focuses on how we could create a more innovative health and care system for the future that's better prepared to deal with the challenges it currently faces, as well as other challenges that we expect to face over the years ahead. Next slide, please. So this reset work, we identified 9 core themes, areas that we believe there are key learnings to capture and have the potential to chart the course towards a more innovative health and care system of the future. Unsurprisingly, inequalities and co-production featured heavily in our work, and we're just about to publish, hopefully in the next 2 or 3 weeks, our final comprehensive report that pulls together all of our thematic areas of work that we delivered during Reset. And hopefully, it's my intention to provide some kind of toolkit or inspiration through this work to point the way to what those lessons learned look like, but more crucially, how we can take those lessons into how we start to look at our next challenge, which, as I've said, is both a workforce challenge and a backlog challenge. Next slide, please. So the Reset report that we're publishing concludes that, whilst there are numerous examples of good practice in co-production across the country, we do need to better understand the needs of the population and use this to design our new services. Fundamental to this is the need to tackle inequalities in the work that we do, ensuring that services are designed to meet the needs of and accessible by all parts of society. So it's a big focus for us here at the HSN Network, and it's now time to start translating these lessons into changes in practice, or wherever practice has been changed, ensure that this is retained and sustainable. Next slide, please. And I just want to say a word or two about some of the work we're doing within the HSN Network on this. It's a piece of work that I kicked off about 6 months before the pandemic really reared its head, but became more and more important as 2020 unfolded, which was to design and to be accountable for a series of diversity pledges to inform the work that we do. As somebody who's worked for 20 years in the NHS and has always been involved in equality and diversity issues alongside my day job, I would say, I started to notice in 2018, 2019 that I wasn't really putting my innovation leadership responsibilities and my equality and diversity responsibilities together and understanding what it is we need to do from a transformation and innovation point of view to do better, quite frankly, at our work in ensuring that diversity, equality is at the heart of our thinking and our design work when it comes to both the design and development and deployment of innovation within the health service. And these pledges that we've adopted nationally is my personal accountability to ensure that the country can do better here. So we're using these pledges to hold ourselves to account for the way that we identify and nurture innovation and the innovators behind them, both inside and outside the NHS. And one of the things that's been striking to me as I've led this work for the last 18 months to 2 years now has been about how the lived experience of our diverse innovators has absolutely unquestionably provided insights into how those innovations that are built by, designed by, co-produced by our diverse innovation or innovator communities always have something more to say about how we can tackle health inequalities within the NHS. And whether that's because we're working with innovators who have a cultural background in the Southeast Asian community and therefore are able to provide diabetes technology or diabetes innovation platforms that are more able to access those so hard to reach communities, whether it's because people inherently build in language barrier solutions into their innovations, and many more examples besides. There's something for me about really recognizing and championing the lived experience of our diverse innovators and recognizing the additional richness that they bring to our challenge of starting to tackle health inequalities. And my stat really is that nearly 20% of our NHS staff identify as being from an ethnic minority. If we don't make sure that our R&D, innovation and research pipelines and access points are accessible to all our staff, then we're pretty much turning our back on 1/5 of the future ideas that could help us to transform our health service. So that's my passion, and that's the work that I'm leading leading on for the NHS, for the HSN network. But as I said, more and more you start to understand how the importance of diversity in innovation has a huge impact on our ability to tackle health inequalities in a better, more co-productive way. Next slide, please. And then another big piece of work which Steve referenced that we've undertaken both again before the pandemic but became more and more relevant as the pandemic continued is our report on levelling up Yorkshire and Humber. I appreciate I'm speaking to colleagues from the other side of the Pennines today, but as you can probably understand, this is a report and a piece of work that's absolutely applicable across the north of England. It focuses on the devastating impact of the pandemic that these had on the north, as we know, and the impact and the prevalence of inequalities prior to the pandemic, which, as I mentioned earlier, has only been exacerbated by COVID-19. But within this, we make the case that there's an intrinsic and unbreakable link between health and wealth, and one cannot be focused upon without the other. I think this is a new space for the NHS traditionally. And I can see, particularly I think through the development of integrated care systems, how the NHS is starting to move across the aisle and work with bodies such as local enterprise partnerships, Metro Mayors and others to start talking about our NHS responsibilities in that health and wealth aspect. So the report demonstrates that a greater focus on health in all policies and the work done by local governments, national governments has the opportunity to support the government's levelling up agenda and combat some of the economic challenges we now face in the wake of the pandemic. And we're working now as a partnership to deliver against our recommendations within the report and drive improvements to the benefit of our population. Next slide, please. So to conclude, it's an obvious statement, and I'll say it again, but the pandemic has shone a bright light on the pre-existing prevalence and impact of inequalities across our population and the disproportionate impact that we see in marginalised groups from something like COVID-19. The time to tackle it is undoubtedly now. We do need to learn from and build upon this increased awareness and media attention that is received over the past year. And I'm very keen that we don't let opportunities such as the increased public awareness of through things like Black Lives Matters and others become a here today, gone tomorrow type of interest. It's really important for me that we absolutely seize upon the zeitgeist that we see at the moment and start to think about how it fundamentally changes the way that we need to think about the creation of services for the future. So the solution isn't just about building more hospitals or increasing the size of the workforce. It's about fundamentally shifting the way that we think about health and care. This means that we do need to pay greater attention to the way in which health can drive the economy and vice versa, that health and wealth link that I've just mentioned. So the new phase that we're entering of living with and beyond COVID-19 and our much longer term focus both need to be informed by utilising lessons and learnings from throughout the pandemic. And this includes the way that services are structured and care is delivered, how individuals access these services, and more importantly, the way in which these changes are identified and implemented. This has to be done through effective co-production with representatives from all of society, and our reset work provides a great catalogue of the exact sorts of learnings from this pandemic which we should be building upon. So how can we use digital as an enabler for change, but one that meets all the needs of all parts of the population? So I'd like to leave you with my closing thoughts and move on to Sally, but we now have a real opportunity to fundamentally shift the way that we think about health and health services across the country. A greater focus on health within all parts of society has the opportunity to firmly tackle the inequalities we face within society. But the work that we do and any changes we make have to be co-designed with representatives from our societies, including marginalised groups, to ensure that their needs are met and we aren't further marginalising them through the introduction of new services and technology. The pandemic provides us with some valuable lessons to inform this, both in terms of the art of the possible and, more importantly, how to effectively undertake activities such as co-production. And it's vitally important we use these learnings to drive reset and realise our ambition for a more innovative health and care system of the future, which is more equitable, more accessible, and better prepared for the future. So that's my soapbox. Thank you for listening. One of the joys about chairing this event is that I don't now have to Q&A myself. So I can move straight on to Sally. So Sally is the Director of Policy at the King's Fund. Sally's had extensive experience in health care and population health policy and delivery in central and local government. Sally was the Director for Social Care at the Department for Health and Social Care, the Director of Programmes at Public Health England, and the Deputy Chief Inspector for Social Care at the CQC. She was also the Director at the Cabinet Office, leading a project on social care funding for the budget in 2017. So Sally will be sharing work from the King's Fund that examines how health and care systems can learn from other disasters to help shape what comes next. We will have a short Q&A session after Sally's session, so please do put any questions you have for Sally in the chat box. We'll be keeping a very close eye on it, and as I mentioned at the top, please do use social media and the hashtag #CollaborativeNW if you are posting there. Sally, welcome, good morning, and over to you.
Thank you, Richard. Good morning, everybody. It's great to be with you all. I'm in the office at the moment because I don't normally have a flip chart in my house. And I was thinking, when was the last time I was in the office? And in a very bizarre coincidence, the last time I was in the office was this event last year. So that feels slightly odd that the first visit in about 7 months, and I feel like it's slightly deja vu, but it's great to be with you all again today. So what I was going to do, and next slide please, I'm going to feel a bit Chris Whitty here, aren't I? What I was going to do today is, I suppose, step back a little bit from thinking about, quite often when people talk about recovery, they're immediately thinking there's a backlog, there's this, there's that, and actually what I wanted to do is step back and think there's a bigger task around recovery and what might that mean. So next slide please as well. I think we're all really aware of what an emergency response looks like. It can look quite dramatic, it can be quite energizing, oddly, around services kind of really cohering behind the emergency at the time, but are we as clear as what recovery from an emergency looks like? And that's the question that we looked at last year. So the Department of Health and Social Care commissioned us to do some research, really as we were still in the height of wave one, to start to think through what can we learn from emergency response and recovery from emergency in other disasters or crises that we could then apply to our approach as a health and care system to recovery after COVID. A couple of things that's just worth reflecting on, because it's quite interesting, is when we started this research, we expected there to be quite a lot of research about recovery from previous pandemics, but actually there's very little research about that. So what we've done is actually look at a much broader set of emergencies and how communities and systems have recovered from them. So to give you a sense of the kind of emergencies or crises that we have engaged with and sort of worked with leaders there to understand what their key learning was. We looked at the Christchurch earthquake in New Zealand, New Orleans with Hurricane Katrina, we looked at the Grenfell fire, a train crash in Canada, Typhoon Haiyan in the Philippines, and bushfires in Australia. And obviously they are all very different types of crises and emergency, but what we did find is some common learning about what recovery really means. So next slide, please. So if the emergency response looks quite familiar, it looks quite dramatic, recovery tends to look a little bit more, I mean, to be fair, it looks a little duller. It's people and communities in rooms working things through. As a civil servant for most of my life, these kind of pictures make me think, yeah, that's kind of what I can do this, I can do meetings, but it does look, it looks quite different to the emergency response phase as you move into the recovery phase. Next slide, please. In particular, what's important to say about recovery is it isn't linear and it will not be uniform for individuals, and certainly communities and individuals will experience different parts of recovery at different paces. and we'll come on to some of that in a moment. So this is just to try and illustrate how bumpy actually a recovery can be. So what this shows here is actually there tends to be quite a big cohering and positive coming together immediately after, or either during the crisis or immediately after. And I think we would say we a lot of us would have felt that with the strength of community connection and community support and mutual aid that was happening, the amount of support across different health and care providers. So I think we probably would say, yeah, we saw that pick up at the start, and then things drop, but then different events trigger. And obviously for the COVID experience, we've had different waves then would have been triggering different reactions to, are you in recovery yet, or are you still in dealing with that disaster? The really important thing to say is all of the experts we spoke to said you're talking about 15 to 20 years to recover. This isn't a, can we get waiting list back? Is it a 5 or a 6 year kind of churning through elective kind of model? This is a 15 to 20 years to get your communities back to where they were before the crisis struck. And I say that based on most of those crises that we've looked at were, if you like, relatively short time frame crises, whereas this has been a crisis that has gone on for more than 12 months now for us. So a real challenge for us to think about what recovery is needed. So next slide, please. If I was to summarise our research, didn't realise I've clearly got animations on these slides. This is the risky bit when you borrow slides from colleagues. Yeah, thank you. That's great. If I was to kind of summarise in one sentence, what does the research and recovery say? It says that resilient communities fare much better in disasters and recover much better. So a huge amount of our research then went on to think about what really does resilient communities mean and what's the role of the health and care system in that. But let's just briefly think, why is it that we should focus on community resilience? So next slide, please. Great, and again, if we can just click through the anime, brilliant, thank you. So I think quite often we've, as a system, been quite good at thinking about individual resilience. We can think about sort of organisation resilience or system resilience, but we've probably, as a system, spent less time thinking about community resilience. But as I say, the research really suggested this was a key enabler for successful recovery. And the reasons for that is really about the human nature of all of us as individuals. So we get most of our support from the people around us. So we get most of our support from our community, whatever our community might be, and I will come back to that later. Individuals just cope better when they feel connected to those communities. Because of being able to connect to those communities, it stops you feeling individually that you don't have resilience, because you can get the benefit of that community resilience. And in particular, you can't have a resilient system unless you understand really what the community needs. So that a real focus on the bit that's kind of been missing in health and care for a long time, community resilience, also then helps reinforce system resilience. So it's really important in that way. So if we move on to the next slide, there are 4 key actions that our research suggested would be critical for successful recovery. And I'm going to talk a bit in detail about all of these 4, but I'll just quickly run through them now. So the first is to place psychosocial wellbeing at the centre of your recovery plans. The second, to ensure communities don't get left behind. Thirdly, to make sure any definition of system resilience includes collaboration with communities and other agencies. And that's it was great to hear Richard talk about the importance of co-production and engagement with communities, because that's completely in line with what our research says. And then finally, recognising the workforce needs support and time to recover as well. I'll talk about that a little bit, but I suspect Chris will talk about that a bit more later as well. So if we move on to the next slide, and therefore the first of those 4 areas. So why focus efforts on psychosocial support? And this is really important to recognise there is a big breadth and range of psychosocial need and support. So the first thing to say is large numbers of people will experience some form of distress after a disaster. It's completely natural that they do. Most people, though, will not choose to seek formal help, or may take many years to realise that they need that formal help. But that said, given the right support, most people do recover, and most people will get that support from their friends and their family rather than needing kind of medical interventions. If we move on to the next slide, this shows the challenge about everybody is on a slightly different kind of spectrum, and a psychosocial response to a disaster is a completely normal thing. So here what we'd say is a very large percentage of the population will have what we might consider normal distress, which is, of course, it's been a very traumatic experience. Of course, that will have an impact on them, but actually they're most likely to be able to recover with support from friends and communities. There's then a much smaller proportion, no more than 20%, that will have a mild to moderate disorder, where that's a more persistent set of symptoms where they may need some support, particularly, for example, from their GP. And then we have a kind of small percentage, around the 3 to 4%, who are at the most severe end of psychosocial disorder, where they may have severe depression, they may have post-traumatic stress disorder. So it's really important to recognise that that is the full range of people's responses. What's really important is that you don't try and put everybody into the bottom of that pyramid, because that actually doesn't help the individuals who are at the top, at the top of the pyramid and just need a bit of community support. So you don't want to over-medicalise and over-pathologise individuals, but equally you need to be able to understand that people will be in these different phases and different levels of need and anxiety. We've done some work with Grenfell and the kind of community supporting victims of Grenfell and the services that kind of wrapped around immediately after the fire. And what I thought was really interesting there is the kind of mental health trust was the main sort of hub that brought together all the public services to support the community. And actually the Grenfell community was saying, we don't have a mental health problem. We've had a massively traumatic fire. What we're feeling is normal. So please stop putting a label on us. So actually what the mental health trust did was really simple things like the lanyard that used to have sort of mental health trust got changed. So they took away the word mental health and started to use well-being. And it's just things about making sure the community then felt the language connected to their genuine feelings and emotions, rather than it being a healthcare system imposing its language and its definitions on a community. So that's a kind of really important thing to think about, how communities will respond to how a health and care system steps into a space. Next slide, please. In terms of what communities might need from national leaders, there are various different kind of models and theories around this. But I think really there's a sense here of you need something that sort of helps people make sense of it and helps people be able to understand how this all fits together and cohere. So there's a bit about just really trying to provide people with that sense of safety, trying to make sure people understand how they can get the support they need at different levels, but it's really about trying to recognise this is normal, actually, and people shouldn't panic unnecessarily. What they need to do is recognise how they can get support, how they can get help, but it's not unusual, having gone through a crisis or emergency, to have these feelings and these needs. Can we move on to the next slide, please, which is going on to the second of the 4 key pieces of learning from the research. So the second one is making sure communities don't get left behind. And I hope pretty much here I'm kind of saying the blindingly obvious to people, but to be honest, a community cannot be resilient if parts of it are left behind during recovery. We know there's a big problem with inequalities in this country. They existed before the pandemic. They've absolutely been exacerbated and exposed by the pandemic as well. So we know we had issues with communities being left behind before. If that continues in recovery, we're going to see recovery take even longer and have an even greater inequity of outcome and opportunity for people. And the key bit being that matters, because you can't be resilient if 1, 2 or 3 of the chains in the kind of links in your chain are weak. You're only, as the quote says, you're only as strong as your weakest link. So you really need to focus on everybody coming on the journey of recovery. But that's obviously not as straightforward as it is just to say it. So if we move on to the next slide, one of the really important things is, what do we mean by community? And it's really important that we look at community through several different lenses, because particularly when it comes to recovery from disasters, some of the impacts aren't always anticipated, and some of the impacts might be because actually that's a community of interest that isn't always an obvious and known community of interest. So it might be that we're very good at thinking about gender differences in response, in ethnicity differences, potentially in socioeconomic, but there could be a whole set of other communities of interest that you need to be thinking about from a lenses point of view. So just as an example of some of those different lenses, communities of interest, where that's around shared interest or shared work. So that could be, as we say here, sports clubs, parent groups, that kind of thing. We then have communities of identity, which is quite often due to shared culture, where quite often it's language and customs which are cohering a particular community and cohering their experience. You can then have geographical communities. Sorry, I briefly didn't have my teeth in then for that word. And geography can mean lots of different things to people. I think the one thing I will say is geography does not mean integrated care systems to any member of the public. That is not a community they will ever feel a coherence to, but it could be towns, it could be streets, it could be tower blocks in the case of Grenfell. So there's a really important sense that you think about what geography makes sense to individual communities rather than what's the statutory footprint we tend to engage with. And then finally, communities of circumstance will mean that people may well come together into a community that you wouldn't normally have expected that group to cohere, but a particular incident or event has meant that they've come together. So if we can move on to the next slide, please. One of the really important things about just kind of saying, make sure communities don't get left behind, is to make sure that you're also challenging yourself to think about what communities might be impacted when, and to get beyond the obvious. So I think it's fair to say in quite a lot of work that there are some particular community groups where you would normally always think, yeah, I need to be aware of how this might be unequal for them. So as I said earlier, deprivation, socioeconomic circumstance, ethnic minorities, quite often older people, for example. So the kind of more obvious list on the left is the stuff that I think we're used to as a system of sort of thinking, have we thought about those groups? But actually what we found through the research on recovery was that there's a whole host of other groups which are much less obvious, and which require some really serious thought as well. And I won't go through each and every one of these, but I thought one of the ones that was quite interesting was middle-aged men and women, for example, because what's within there is middle-aged men and women who have worked for most of their life, have been fairly comfortable, but maybe for the first time find themselves needing financial support from the state, or needing much more intensive support from health and care services than they're used to. So you have a group of people who sort of don't really know how to interact with some of the services that they're going to need to trust and rely on to recover from an emergency. So that's a particular challenge for that community, which is, it's not about, is their need more or less severe than any of the others on this list, but it's more that actually they have less experience and less trust in being able to navigate through some of those the places where there might be help. So as I say, do keep kind of a lens on those less obvious groups as well. And we'll come on to talk about the workforce at the end. I think it's one of those, the workforce might be less obvious in some recoveries and some crises. I think in a pandemic, the healthcare workforce is a very obvious kind of group that we know needs support and help. But obviously in things like train crashes or earthquakes, it might be less obvious that that's a group that needs support. If we move on to the next slide, please. This is the third of the 4 key areas. And given that I'm talking to a group that's a collaborative here, I'm very much hoping I am preaching to the choir on this one in terms of why is multi-agency collaboration a really important part of recovery efforts. So for a start, it supports more coordinated recovery. It builds better community resilience by bringing broader perspectives into what recovery looks like. And really importantly, it can change the dynamic where you're doing things with communities rather than doing them to or for communities. And again, that reinforces some of the points Rich was making in the introductory presentation, where that's a really big shift for us as a system, but a really important one that we do. But we all kind of know that multi-agency collaboration is really important, and there's been some great examples in the last sort of 14 months in responding to the pandemic. We also know that the history of the health and care system suggests this stuff can be hard as well. So if we move on to the next slide, it is worth being honest with ourselves about what can get in the way of that multi-agency collaboration. So the first is complexity. It can just be quite overwhelming, the sheer number of people that need to be involved. And that can also mean that there's quite a change in personnel throughout different phases of recovery that can kind of mean that you're sort of going back to the start to reform relationships, etc. There are some challenges around leadership and accountability, where there can be a lack of clarity around what the governance is, what the shared vision is, how you are ensuring decision-making is appropriate for all the different organisations, and that the culture is really driving kind of the outcomes that you want. And also it's important to say it can be really highly charged. We're particularly at this point, we're talking about trying to get organisations to collaborate who are exhausted, absolutely exhausted after 14 months of fighting COVID. So it's obviously, and we all know individually that if we're highly stressed, that can mean that it's harder to maintain relationships, to maintain performance. You can snap a bit more, and that translates to organisations as well. So I think we do have to realise it can be highly charged. For me, that says we also then have to be forgiving with our partners, that we have to recognise what might be sitting behind some behaviours, and recognise that in effect, do what you would do if it was a friend. You'd sit down and have a coffee and try and work out what's happening, and you need the equivalent of that organisationally to understand what might be causing that particular stress for that organisation. So the quote here is kind of, I think, again, saying stuff that a lot of us would know here. It's the biggest challenge and a big barrier to successful recovery, but the prize of it is quite a huge, if you can get it right, which is really, really important. So having focused a bit about the barriers, if we move on to the next slide, that I thought it's also worth thinking about where we can focus our work. We got the next slide. Yeah, lovely, thank you. So the first is around really focusing on understanding, sorry, now my internet has become unstable, so I hope it's not too unstable for everybody else. I'll keep on going. So the first is to understand social capital and how interpersonal connections can support recovery. So that's some of the really important things about connecting with and working with communities rather than just being about delivery to communities. Part of that is around how do you reduce barriers for communities to engage with services and to engage with each other. And that can be very practical things like transport to meetings, paying for people to attend meetings, making sure papers are shared in advance of meetings, or that there's necessary interpreters, etc. So it can be really, really practical. The third area is around, and this is something that came up a huge amount in the research to date, is the importance about engaging this set of sort of people who are, you know, connectors, translators, bridges, whatever they might be, that kind of each community seemed to call them something else in how the system worked, but it was a really important place they held between bridging the gap between services and the community as a very trusted in both directions, and that was really, really powerful. Sometimes that can be people in formal institutions like religious institutions, but it doesn't have to be at all. If you think, particularly again using the Grenfell example, that really was a community that self-organised itself to then have a kind of leadership group that helped be those connectors and those bridges. So really important. And then finally, proactive contact, where you don't want to wait for people to come to you as a service. You need to be going out to communities to understand what communities might need and where they might need it. And in particular, having some of those conversations in people's own communities and their own homes can mean it's a better quality conversation, because people feel more at ease than if they're kind of in a service and feeling that kind of potential stress by that. So definitely that proactive contact, really important. Then if we just move on to the final of the 4 key areas, which is focusing efforts on supporting the workforce. As I say, I will fairly quickly run through this because I know this is a theme that will be cropping up throughout the morning as well. So why do you need to focus on the workforce? Well, the first reason is because the need to deliver health and care services doesn't go away. In fact, it gets harder and greater both during a pandemic and then after the pandemic, when you are dealing with different and new health needs because of the pandemic, but also with the backlog of care. So there's something about how you can make sure you continue to deliver services in a way that isn't continuing to be detrimental to the mental and physical well-being of staff. Staff can deal with a huge amount if it's a short-term crisis. You can't expect them to work as if it's a short-term crisis for months after months after months, and in this case, years after years. So you really need to shift to have that focus on their own well-being. You absolutely need to do that because you do not want to lose your workforce. As Richard kind of alluded to with some of the stats, there's quite high numbers of people thinking about leaving the sector, and that would create huge implications for staff that remain in terms of the pressure on them, the ability for us to deliver high quality care for patients. So a real challenge there. And there's also a bit about actually staff aren't just NHS staff or social care staff. Staff are part of the community as well. So actually you can kind of reinforce if your staff are resilient, if the well-being of your staff is well looked after, that can have ripple effects in communities as well, which is important for us to think through. And then the next slide, please. This, in terms of what can happen after a disaster, you, again, as with the kind of general individual resilience, you can have people on a spectrum of the level of need they might have, but it is worth saying for health and care staff that can be skewed to the more severe end of the spectrum because of what they've had to witness and see and deal with throughout the 12 months. So you might find a higher proportion in the workforce than in the general population with post-traumatic stress disorder. You will particularly find a lot of people with fatigue, with burnout, and that starting to lead into depression and anxiety. So there is a big set of real challenges in terms of how you support the workforce as well as possible. And then finally, moving on to the next slide, there are some kind of a mix of practical things you can do to support the workforce. So what our research showed is making sure people have adequate breaks, both kind of during the working day, but also really importantly as time off from work. So they're not kind of feeling constantly on is really important. And that will, I think, be a big challenge for sort of as you move out of waves of COVID, but sort of the pressure comes on to absolutely ramp up backlog. Actually, you can't just go from running 100 miles an hour at one problem to running 100 miles to another problem. You've got to allow staff a break. Lots of things around the supportive work environment, things like access to hot food, access to rest areas, all of those kind of what seem like really small things that can make a massive difference to the resilience of staff. Really clear communication with staff about how you are supporting their well-being, what offers are available to them, access to training and education programs, and then importantly access to different types of psychological interventions for the workforce. And sort of normalising this, so staff understand that looking after themselves is their first step to them being able to look after their patients, and they shouldn't sort of deprioritise themselves, that they will need help at different times. So we can move on to the final, these are the final set of slides. So just to kind of summarise, all of of the evidence of our research so far points to a real focus on community resilience rather than individual or system resilience. And that means psychosocial wellbeing, don't leave communities behind, multi-agency collaboration and workforce support. Right at the start, I said, what does recovery look like? If we move on to the next slide, this is what my research team kind of concluded is what recovery looks like. And this is a picture after one of the Australian bushfires of a kind of intergenerational community connection here. It's a slow and steady, really kind of not giving up, not forgetting about different parts of the community. But recovery is possible if people stay focused on it and if people realise it's a long haul, as I said, of that sort of 15 to 20 year horizon, but it is possible for communities to recover from very, very dramatic events. And very finally, kind of final quote from one of the experts globally, the Australian Disaster Handbook Collection. Recovery is a complex process of individuals and communities who've been impacted by a disaster, working to resolve those impacts that have had an impact on the trajectory of their lives. So it's complex, but it is doable if you are kind of managing all of the different aspects of it. So I think, Richard, at that point, I'll pause and hand over to you.
Sally, thank you so much for that. I mean, I know this is a masterclass session, but that was an absolute masterclass, really fascinating as well. And yes, just to remind everyone to use the chat box. I can see the questions starting to come in. I'm going to use Chair's prerogative actually to just ask a couple. And I know we've only got you for a short time, but I was really struck by the notion of it being a 15 to 20 year recovery journey. And as you said, I think midway through, and that's if you manage to take communities with you. There's a danger it could be even longer than that. I guess for me, there's something about that inconvenient truth, maybe compared to the more political timeframe that any government, to be honest, not necessarily just this administration, but any government would want to move ahead at. And I sense that there may be an interesting tension between the reality of the timeline of our recovery compared to the political imperative to kind of draw a line and move beyond. Is that going to become a clash for us, do you think? And is there a way that we can influence thinking so that we can start to talk more about a 15 to 20 year time horizon?
Yeah, a really good question, Richard. And I think the short answer is yes. I think it will be a point of clash. I think it's worth thinking about two different types of recovery, though, in where that clash might happen. So I think when the government is thinking about recovery at the moment, they are predominantly thinking about recovery of healthcare services, or they're thinking about kind of economic recovery, and within the economic recovery, probably recognising that wider community side. I think when it comes to the healthcare recovery, there will be a tension that government will want to go really fast, or faster than the service thinks is possible. So what we've been saying from the King's Fund perspective, and I think Chris has been saying similar at providers, is you need to be realistic about what the pace is, and then you also need to be honest with the public, because actually what you don't want to be pretending is that you can recover this in 2 years' time, when actually it could take 5 or 6 years' time. But you do need to be clear about that. So what's the trajectory, and are you on track with it? I think the sort of community recovery bit is much, well, I suppose in some ways it's a bit more hidden, in that it's not a, one bit of data, it's not the waiting times data, it's not GDP growth, it's a whole host of things. So that will be, what's the government's approach to levelling up? What are they going to do in the education system about helping kind of catch up on lost learning and greater learning and development? So there's a whole host of things there. What you kind of want to make sure is that some of the general ethos of the research is then factored into some of those policies and thinking going forward. So as an example of where perhaps it isn't aligned to our research at the moment is in education. There seems to be quite a big push on discipline and structure in the kind of how you help people catch up. Quite a lot of our work on the kind of psychosocial side to say, actually what you need to focus on right now is connection, creativity, play, reconnection. It's probably not discipline. The thing is that those kids want or need right now for their long-term well-being. But yeah, it's going to be I think that that tension between the pace of recovery of service is going to be really interesting. I think one thing I will say on that pace is we have tackled waiting lists before in the NHS. Like we have, you know, the 2000s waiting lists were in a dire strait as well. So we do know we can do it. It didn't happen overnight in the 2000s. It was sort of a 7-8 year slog, but we know we can do it. So we kind of need to think about how we can apply the lessons learned from the 2000s in a 2020 appropriate way. But we should be able to do it.
Thank you. Nice, because nice to have some positivity as well. That's good. I think, and I'm going to just ask one further question. Oh, and as somebody who runs a multi-academy trust of secondary primary schools in South Yorkshire, I completely agree on your education point as well. I think that's another really interesting sector to be taking an eye on in a post-pandemic sense. My favourite slide of yours, Sally, is the graph of positivity or negativity, I guess, in a timeline horizon. It's really interesting, isn't it, to look back and plot. You can almost put on that graph population clapping outside markers to see exactly where we are and where we've been on that journey. But I think it's probably, is it fair to say that graph is as true for organisations and for multi-agency collaboration as it is for individuals? And the second part of my two-part question is, you got me thinking a lot in that multi-agency collaborative kind of points that you were making about, although the timelines aren't exactly consistent, when we look back with the longer lens, maybe 10 years, we'll be looking at integrated care systems having been conceived and born in an area, in an aspect of, or in an era of pandemic. And I just wonder if that's going to create a different culture around integration and collaboration than might have been the case if we'd have been doing this 8 or 10 years ago, or even 2 or 3 years into the future. So I guess just some thoughts about the multi-agency part of this and how the pandemic might shape our system.
Great. You're very good at these questions, Richard. It's keeping me on my toes. So your first question about does it apply to organisations and partnerships as well as individuals? Absolutely, it does. So what you'll find is individuals are experiencing it will be a different stage in the kind of, they'll all have their own individual graph. An organisation will have their own individual graph that may or may not coincide with the individuals that work within it. And then partnerships and collaboration will as well. But one of the tricky bits for those partnerships is that you may find one organisation in that partnership is absolutely in a dip when another bit of the organisation or the system is feeling okay. So being really alive to where are other organisations in this this journey and recognising people will, you know, it's a bit snakes and ladders, isn't it? People will kind of dip for reasons that might not be obviously apparent, and organisations will dip in their culture. So yeah, absolutely agree. On the multi-agency point, I think it's a really interesting example. There's certainly been a huge amount of positivity in joint working. I'd say there have also been some stress points in joint working. So it hasn't all been all positive for that. Most of those stress points were earlier in the pandemic, and I think things have kind of worked through more. So yes, there is absolutely the potential for that kind of experience, the kind of the moment of birth being in that moment of crisis, meaning they could well cohere. One of the bits though that I think from the King's Fund we'd say, and very conveniently we published some work on this only yesterday, is integrated care systems for us are one part of how you do collaboration, and for us place-based working is really important as well, place-based partnerships. So we published something yesterday on our work with looking through at how ICSs are supporting work at place-based level, as well as set out some key principles. But I think that the key kind of bit is that you don't want the ICS to cohere so much that it's excluding the important place and neighbourhood level work, where the vast majority of the joined up care and collaboration that most of us will experience will happen from. So you kind of need that the kind of born in a fire moment to then also apply to how the kind of different kind of footprints within the systems are also developing.
Yeah, no, I completely agree. And for me, ICS is a shorthand for both ICS and place. I think it's, ICSs don't exist without place fundamentally. That's my take on it. Just moving to the questions, and thank you very much for the questions. Faizan Ahmed, you ask a question here about the additional impact of long COVID. Are you happy to just pop on the mic and just ask that question of Sally, please?
Absolutely. Thank you, Richard. Thanks, Sally. It was really about, you talk about resilience. So I'm a GP by background. I'm Deputy Medical Director at NHS England Improvement North West Region. And we're just starting to realise this physical entity that's, it's been termed long COVID, and we'll think of a snazzy title for it later down the line, I'm sure. But it's there's the bit about the psychological impact, and again, we're only recognising that, and your data with other comparative events is really powerful. But how do we, given the levels of unemployment that have happened as a result of COVID and the additional impact potentially of this physical new illness, just wondering if there's any early learning from elsewhere around that.
So Faisal, a really good question. To be honest, the King's Fund hasn't done any work on kind of modelling the impact of long COVID, because what we've kind of been doing is general lessons about approaches for recovery rather than the specifics of what does the trajectory look like with kind of waves of COVID and long COVID. I think it's without suggesting what Anita's going to talk about, Anita and her team kind of tend to do much more about the forecasting of activity. So I think from a long COVID point of view, it clearly will have an impact on service need. And you can start to see some of that response now with some of the kind of additional rehab services and different focuses on long COVID. So that's an important kind of system or service delivery response, but there will also need to be a kind of what is it doing to individual resilience and community resilience more generally. And I think we don't really know, because we don't quite know what long COVID is and how long it might last and how significantly it will impact on individuals. So it's one of the things that the system will need to keep an eye on. And it's where I say there's been when you think about kind of what's the delivery challenge for services, there's obviously the backlog, but there's also a whole set of new demand for services that could be because of long COVID, could be because of the mental health impacts of lockdown, could be because of the economic circumstances and consequences of lockdown. So you will start to see a different shape of need for health and care services as well. So it's not just you're turning back on the tap of what it looked like 18 months ago. You will have a different a pattern of need in the system as well.
Thanks, Faisal, and thanks, Sally. Thomas Casey, really love your question about the metrics of community recovery. Do you want to just pop on and ask that again for Sally, please?
Yeah, thank you for the presentation, Sally. I think I think you made the point right at the end about sometimes, like with financial, you can see there's measurements in place. I think it's quite a hard question. That's why potentially we don't address things, because we can't see it. So I was trying to think myself, but how can you measure things at a community level to sort of make it visible, and so we can sort of see has there been progress and maybe where progress needs to be made? Yeah,
it's really hard, isn't it? And I can't immediately think of what are the measures that would show kind of community well-being and community resilience. What I think, one of the bits which I think will be helpful is the Office of National Statistics are doing work on a kind of a well-being equivalent of GDP. Now that works at a national level, and I think the consultation is currently still open on that one, but that is, I think, done well, that can become a useful counterbalance to GDP, in that actually you can be looking at both to say, are both going in the right direction, or is GDP kind of heading in the right direction, but well-being is kind of faltering some way. So I think but the well-being measure, it's not a single measure, it's a collection of lots of different measures, because well-being is so many different things. So I think that's the beginnings of something that what you want to have is a way to ensure that well-being is a core part of the conversation, and not just kind of after you've made decisions about the economy or about service delivery, you then think, oh, look what's happened to well-being as a result. So that's a key bit for me.
Yeah, thank you.
Yeah, thank you, Thomas, and thank you, Sally. I mean, I'm sorry we can't take everyone's questions, although I'm sure some of them may also pop back as relevant for Chris and Anita later. Sally's got to leave us. So, Sally, thank you so much for joining us. I know you've had to change your day around so that you could make it, so thank you for that. We do appreciate it.
No worries, and I'm aiming to be back for the Q&A at the end if everything goes to plan at my end.
We may see you again. Thanks, Sally.
Thank you. Bye.
That's great. So I'd like to move us on to Chris's presentation now. So many of you will know Chris from his work as Chief Executive of NHS Providers, and he's obviously spoken at this event for the past years, which is fantastic. Chris joined NHS Providers as Chief Executive following a career spanning the public, private and voluntary sectors, and he's going to share his analysis of system pressures over the past 12 months and what he believes the future will hold for both recovery and transformation of services in the workforce. And as always, there's time to ask questions for Chris after his session, and please do get in the queue, put your questions for Chris into the chat box, and we'll pick up as many as we can in the Q&A session. Chris, thanks very much for joining us. I'll hand over to you.
Thank you, Richard. Good to see you and good to see everybody. Always one of my favourite events of the year, so good to be back with you. So if we could go to the next slide, please. So there we go. I always like to start off a presentation like this with a bit of a mood music slide. So here's my mood music slide. As you'll see, it's very busy and crowded because it does feel like there is a lot going on. I won't run through all of the individual items, but there just is a sense of how incredibly busy it is at the moment with lots of different priorities. So next slide, please. So what I'll do is I'll really just have a quick reflect back and just think a little bit about what do we think we might have learnt over the last extraordinary year and a bit. Really talk a bit about the challenges ahead, and that's really where the focus of the presentation is. And then just talk a little bit about, given that the challenges are pretty large, about what is it that we need to get right to meet those challenges. So it's a three-part presentation. So if we go to the next slide, I'll just start by thinking a bit about the lessons learned looking back. So, and then one more. So, I mean, we'll all have our own lessons, but what I've put down here is 7 that are my personal kind of lessons. I think the first is a reflection that the NHS and the wider healthcare system is capable of much faster and more extensive change than we might previously have thought. So there's a sense, isn't there, that the NHS and the health and care system is a bit of a supertanker that takes time to sort of change course. But if you actually look at how much we did, how quickly over the last 12 to 15 months, I think Nikki, do you want to mute?
Oh, sorry.
What I think it shows is really how much change and how fast we can make. And if you think about some of the things that we've done, for example, freeing up those 30,000 beds for coronavirus, that was a really good example, I think, of how we moved, I think, much faster than we might previously have thought possible. What we get consistently when we talk to our chairs, chief execs and senior leaders is a sense that certainly that nearly, well, all of them say that what COVID has done is forced a much more rapid, consistent and successful vertical place-based, in other words, take, for example, a local authority footprint and then health and care working together in that footprint, but also horizontal system based. So, for example, 3 neighbouring acute trusts working together. But COVID has forced much more rapid and consistent collaborative working. And there is an interesting question for us, which is if you think that collaborative working is key, as I think we all do, there's an interesting question about which is actually going to end up forcing more of that or enabling more of that. Is it the experience of the last 12 months or is it the bill and all the guidance that we've got coming? My personal view is it's actually what's happened over the last 12, 15 months. I think there is a real sense that what we did in COVID was empower frontline NHS leaders within clear strategic objectives, and that sense of stepping back from top-down command and control, that worked very effectively too. If you look where we were before COVID, there's absolutely no doubt that both in health and in social care, there was a very serious capacity and demand mismatch. We know that social care was becoming more and more precarious. We know that the NHS was having some of the most difficult performance statistics in a decade. And that really, for me, is due at its very top level about that capacity demand mismatch. So just to make the point, that is now worse in terms of given the levels of demand we now have. There's no doubt that our staff were absolutely extraordinary, but it's pretty clear that the workforce model is unsustainable. I think, again, in both sectors, both health and care. And I don't think there's an immediate solution available. I mentioned the 3 to 5 year gap, and I'll come back to this, is that what is interesting is that what's happened over the last year has stimulated a lot of interest in certainly NHS careers, and that may provide a means over the longer term. Once people have gone through the training and development pipeline, that may provide us with a means of expanding our workforce if we can fund it. But at the moment, there's no immediate prospect, it feels to us, of really addressing that fundamental insufficiency in terms of the size of the workforce. One of the phrases I used in the pandemic on the media was the fact that a crisis always finds the most vulnerable and weakest links in the chain. And there's absolutely no doubt that yet again, a bright light was shone on our social care system. And Richard, I was very glad that you spent your presentation really focusing on health inequalities. I think one of the real shocking things that's happened over the last year is the degree to which COVID has exacerbated those inequalities. And again, I think, Anita, if I may say, your organisation is doing some really fantastic work in this space, and more power to your elbow to highlight those inequalities. But I think what's interesting is that tackling those inequalities offers the potential for a powerful unifying mission. Okay, so if we go to the next slide, please. So what are the challenges ahead? So next slide, please. I suppose my thesis really is that the biggest challenge of the next phase is probably, in one sense, the scale and the width of what needs to be delivered. Again, we'll all have our own way of cutting this, but the way that we think about it is there are a set of things we're going to clearly need to do. We're going to need to deliver the long-term plan. We're going to need to learn to live with COVID. We're going to need to clear the care backlog. We're going to have to make our workforce model more sustainable. We're going to have to move to system working. We're going to need to make the NHS money work, and we're going to need to reform social care. So that's a pretty big agenda. And I thought what I'd do is I'd just literally take you through a slide on each of those to just give you a sense of how we see what that mission is going forward. So next slide, please. So a bit of a fun slide. This we've always had fun with this slide, which is basically trying to put the long-term plan. I think it's 130 pages of it onto a single slide, but this is our attempt at doing that. So if you remember, there were a series of really important things that we put in that long-term plan. I think all of us felt it was a very good, strong forward vision of what needed to be delivered. And we need to get back to delivering that long-term plan. I'm not going to walk through each individual point. I mean, they're all really pretty kind of well known, but that was a pretty substantial and significant agenda to deliver. Again, I think you may have heard us say, and we didn't always make ourselves entirely popular with the powers that be in saying this, but we always felt there was insufficient funding in the May government revenue settlement on the NHS side of the house in order to actually kind of deliver that long-term plan. So we already had a mismatch between what we were being asked to deliver over the next decade and certainly the funding that was available for the first 5 years. And again, as Anita will point out to us, just also don't forget that when we had that May settlement, the May government settlement with the extra money, it actually left some important bits out. It left out, for example, capital spending. It also left out the education and training budgets. There was also a question about whether there's sufficient funding for public health. So before we even started, there was a mismatch, as I said, between what we were being expected to deliver and the money that was available. So we need to get back to doing that. delivering the NHS long-term plan. But next slide, please. The game has also changed in terms of we need to live with COVID-19 longer term. I mean, we are all on, well, I certainly feel, I don't quite say this publicly for obvious reasons, but I feel slightly on tenterhooks in terms of working out what's going to happen next. I personally think it's rather more precarious than this sort of prevailing mood of we're on a one-way, inexorable way, road to freedom and back to normal. I personally would be very surprised if we didn't have some pretty significant bumps in the road. You just need to turn on, for example, the radio this morning and listen to what's happening with a potential triple mutation in India and see what's happening in India to kind of recognize that actually there is significant risk here. I genuinely can't see how we're not going to be in a position where for a number of years we are going to need to live with COVID-19 and its variants. So that is going to mean a large-scale, sophisticated test and trace operation with complete geographic coverage, ability to track variant spread, ability to react at pace as soon as we start seeing those variants spread. There will need to be, in my view, an annual vaccination campaign. The Secretary of State announced on Monday that we're going to have autumn boosters. We obviously need to work out how we run that alongside, if we can, ideally, flu jab one arm, COVID jab in the other arm at the same time. But that's a really big, as we're discovering at the moment, a big issue. We've already talked about long COVID. We've talked about the extra mental health demand that is definitely being created as a result of COVID. There will be other COVID-created demand. I mean, we still hear people feeling they're still in relatively early days of working out what potential more long-term issues might be caused for people who've gone through the more extreme versions of COVID. So we also need to be able to flex for more COVID waves. Since the issue of the day, in a sense, is that elective care backlog, the key is we need to be able to carry on getting through the elective elective recovery work in our hospitals, whilst also being able to deal with COVID. And I think, as we all know, again, the capacity problems in hospitals at the moment mean that as soon as you get a difficult winter, or as soon as you get a even, small to medium sized wave of COVID, the reality is the only way we can cope with that is by dialing back on elective care. So I think there is going to be a real need to think about how do we physically configure our hospitals to ensure that we can carry on with both COVID and non-COVID care more effectively. We're getting better at it, but we need to get an awful lot more better at it. We clearly need, when we talk to our trusts, they say that they want to be able to train more staff so that they are able to be redeployed with the right skills to particularly look after the most seriously ill COVID patients. And we need to look at the pinch points. Again, it's pretty clear as soon as you've got COVID around, you do have to have, as we know, rigorous infection control. And that, again, requires us to absorb that loss of capacity that comes from having rigorous infection control. So we know we were already tight on capacity, insufficient bed capacity before we hit COVID, but we're actually going to have less capacity in our hospitals. This isn't just about hospitals, but I'm picking on hospitals at the moment because of infection control. And it's pretty clear to us that will require a reconfiguration of the NHS and the shape of our public health system, which, as we know, is in train, but it's also going to require more money and more people than, for example, the May government settlement envisaged. Next slide, please. We've already talked about addressing the care backlog. Sally, I think, made reference to the fact that we were doing media work over the weekend. That's on the left-hand side of the screen, really just trying to start to manage expectations here about what is going to come. We actually don't know the full scale of the backlog at this point because we don't know what the referral bounce back, in other words, the people who the statistics suggest should have come forward last year but didn't. And again, I know Anita's doing some very interesting work in this space about exactly what that referral bounce back looks like, but we just don't know what it looks like. And we do need to be careful. I mean, the media and the politicians, for reasons I understand, focus on elective and cancer care backlogs, but actually the reality is in mental health and community services, we have significant backlogs too. I think the early indications are, and you heard us say this if you heard our intervention at the weekend, is that this is going to be a very big issue. What we specifically said, and you can see the headline on the left, is that talking to trusts who've done a month's planning work on this, those who feel they're most have the biggest problem are saying to us that on current trajectories, they're thinking it's talking about something like a 3 to 5 year timescale needed to get through those backlogs. Now, we all know that is absolutely inappropriate, and we need to go faster than that. But if we're going to do that, we are going to have to be radical, bold, and transformative. And that was, again, the rest of the message we were trying to deliver at the weekend. We're going to need to have a radical approach to the pinch points. We are going to need to expand capacity. We're going to need to make efficiency and productivity gains via collaborative working. We are going to need, as I've already said, to reconfigure acute care to avoid elective disruption. We are going to need to have new care models by specialism. And we are also, and this I think again is going to be really important, is we're going to need to manage public and political expectations, because I think there is a significant risk here for the NHS, which is you saw what happened last summer at the point when we started to recover care. There was a very strong focus from a large number of people basically saying faster, faster, faster. Why aren't you going faster? If it is going to take us a number of years to get through this backlog, which I think it probably will, hopefully not 3 to 5, a shorter number than that, then clearly we are going to need to not only manage expectations, but also, for example, manage people who are sitting on a waiting list, and, for example, get, I think, much more sophisticated about that relationship between primary and secondary care. Because if you're stuck on a waiting list, the first port of call is your GP, and we've already got very clear evidence from GPs that they are beginning to see significantly increased volumes of inquiries and requests for consultations as a result of people who want to know when will they get their elective surgery done. So next slide, please. So alongside this, as I've said, we need to get to a sustainable workforce model. And the way we describe the current, I've already explained said that we've got a demand capacity mismatch. Our very simple description of how we're trying to close that demand capacity mismatch is by asking staff to work harder and harder. And that is clearly no longer sustainable. It does help that there is a manifesto commitment on 50,000 extra nurses, but to be frank, that's just the nursing part of the workforce. And it's also, I should add, just the NHS part of the workforce, of the health and care workforce. We do absolutely need to be clear about what is the total size and shape of the workforce expansion that is needed here. And and again, there's a helpful bubbling up of this issue. And again, Anita, King's Fund, and Nuffield Trust, alongside ourselves and the Academy of Royal Medical Colleges, have really sought to put a focus on this. Is we just need to get to a place where we're honest and open about what the size of the future workforce we need to meet the expected demand is, and stop having attempts to do that vetoed by the centre of government, particularly the Treasury. And we need to then find the funding, or at least be open about whether we can or can't find the funding to fund that expansion. As I've said, there is hope on the horizon if that post-COVID surge of interest in NHS careers does provide a midterm solution. But as I've said, it needs to be funded. And let's be clear about this. The debate is not just about the numbers or the funding. It's actually also about delivering the people plan to make the NHS a great place to work, with 21st century working conditions, good development opportunities, new roles, and fulfilling careers. Again, I think it is still a source of some dismay for me about the fact that actually we still do seem in many places to not recognise the importance of, for example, being able to offer flexible working conditions to our staff. And if you talk to and look at the evidence, for example, the NMC evidence on people who are leaving the register, a lot of it is focused around, interestingly, not on the pay, but it's focused on the level of demand and pressure people feel themselves under, and their inability to provide the quality of care that they think is appropriate, and the fact that they're being asked to bear this unsustainable workload day after day, and we don't have the right working conditions in place. Now, I know that some of the answer to that is an expanded workforce, but some of it is also delivering the people plan. We also need to have the serious targeted action to manage post-COVID retention risk. So we know there is a risk, and we've seen this, for example, in other nations post-MERS and post-SARS, when people came under real pressure, there was a higher number of people leaving. Just to give you one little vignette, I mean, what's interesting is that I think what worries quite a lot of trust leaders at the moment is the fact that it's people closest to retirement who are likely, potentially most likely to leave, and that would give us a significant gap in the leadership cadre, because obviously if you look at leadership cadres, they do tend to be staffed with more experienced, not exclusively, but there is a higher proportion of more experienced and older staff in that cadre. We also need to resolve the pay issue. I mean, we remain extremely disappointed and frustrated that the 1% offer was made when we'd already built into the assumptions it was going to be at least 2.1%. Next slide, please. So we also need, as we know, to embed system working and health and care integration. There is major structural change on the way that will require significant energy and focus to make the approach work locally, just to make the point as we exit peak COVID. I think there's strong support for the strategic direction of travel. I think there's a real desire to make sure that we get an enabling framework that allows local systems to take full account of local needs. We have a joke at NHS providers, which I've probably said at each of the last 3 of these events, which is, if you've seen one ICS, you've seen one ICS. The answer is none of them look like each other. Their heterogeneity is actually their single biggest feature. The issue, though, we think, and certainly we did a webinar for about 90 of our senior leaders yesterday with NHS England and Improvement, is there is a lot of plumbing and wiring issues to sort out on what could end up being a potentially very crowded pitch. And just to make the point that on that pitch, you now have NHS-EI regions, you will have ICSs in their 2-part form, the Health and Care Partnership and the ICS NHS body. You have provider collaboratives, you have places, you have trust/foundation trusts, and you also obviously have potentially local authorities. You also have at a neighbourhood level primary care networks. So I do think there's a lot of work to be done to make sure how all of that pans out. Who does what? How does the money flow? How do the accountabilities align? How do we make places and provider collaboratives work? How does ICS governance work? I think the nervousness, and this is a quote from the departing Marcel Levy, who's the chief exec of UCLH on the left-hand side, these could end up being very boring discussions about ICSs that could quash system working. So how do we avoid pulling senior leadership time and focus excessively onto structure, governance and accountability at a time, to be frank, when we need, the whole point of ICSs is actually, it's about improving patient care, improving outcomes, integrating pathways and ensuring our staff are able to do what they need to enable that those better outcomes and that better care. And yes, whilst it is, absolutely, it's really important how many providers and which providers are on the ICS NHS body board, but actually that ain't going to make any difference to those issues. So next slide, please. There will also be a need to make the NHS money work. And so the current model in the NHS is you get what you spent last year, plus all your COVID costs covered. We're going to need to go back to delivery against a fixed budget, which will require efficiency and productivity savings that we're currently not required to make. But we're going to be asked to be doing that at a time when provider deficits rose last year up to 980 million, despite the fact that we have the first year of the increased NHS funding. We all know that underlying deficits are increasing. We know that the underlying recurrent run rates are now very unclear as a result of having to move to this model of what you got spent, or block and top up as it's called, what you spent last year and all your COVID costs topped up. We know that the ability to return to stretching SIP savings is not entirely clear given how much else we've got on, and where, to be honest, the incentives for financial discipline are much weaker. And we're going to be doing this at a point when we're also making a major shift from the current model where effectively the money goes to the CCG, they contract with an individual provider, and that's how the money works. but actually we're going to be now moving to a system where the ICS gets a pot and it's going to need to work out how it divides it. We also know that at the same time, public finances are going to be very tight, judging by the forward projections in the last budget, and the government will want an appropriate share of that tight money to be spent delivering the manifesto commitments. So I suppose our view would be that if you got in the TARDIS and went 5 years forward, what you could say is all the conditions were there to have one of those points where the NHS lost control of the money. I mean, you know, in our view, people are underestimating the scale of challenge that will be required to make this work effectively, or get back to working effectively, to make it work effectively. Next slide, please. And then, of course, this is all before reforming social care, where we know that this is a multifaceted problem. I mean, a lot of the conversation tends to focus on what we call the DILNOT cap, the DILNOT, you know, in sense of how much personal financial contribution should people make. But what we're quite worried about is that an excessive focus on that actually ignores a whole bunch of other things, which is there's an unsustainable workforce model. The eligibility criteria have tightened so much that actually we're not getting people who need the service, access to social care services aren't getting them. We know that the local authority funding element of this is now really precarious. And we also know that the provider marketplace is deeply unsustainable. A lot of it propped up by private equity companies expecting a return that they haven't been able to and are unlikely to be able to realize. You've then got the kind of political complexity of this is the third rail of British politics in terms of, if you remember, the Labour Party at one election fell foul of, you know, the death tax. Theresa May fell foul of the dementia tax. So actually the politics of this are really quite difficult. And then you've got the complexity of addressing all of the above issues that need to be addressed. And then you've got the costs involved. So again, I've just put on the right-hand side just that clipping from the Health and Social Care report. And I know Anita's, because I've had the benefit of seeing Anita's slides. Anita's got a very good slide, which kind of just sets out what the costs here might be. But if you just took 1 point, from the Health and Social Care Committee, it's 7 billion a year, which is, to be frank, eye-watering. So next slide, please. So effectively, if you wanted the glass to be half empty, what you could say is risks abound. And the risks might be we try to deliver too many priorities post-peak COVID as we come out of COVID, but learn to live with it. There is insufficient money. There's a workforce crisis through staff leaving, or we try to continue to ask them to bear an unsustainable workload, and that doesn't work. We lose public and political confidence because we can't clear the care backlogs quickly enough. There are further waves of COVID-19 that we are insufficiently prepared for, driven by variants. The move to system working ties health and care in distracting bureaucratic structural knots. We lose control of the finances and we flunk proper full social care reform again. That's a pretty depressing list, isn't it? Which is precisely why I'm not going to end there, because I think the most important thing of all, perhaps, is having that resilient positivity that actually we have done some extraordinary things in health and care over the last year. And actually, although the challenge is significant, we absolutely can meet it. But next slide. I've just got 4 thoughts to finish up on what we think are the critical success factors in meeting those challenges. So the first has got to be prioritization. There is simply too much to do with the current workforce capacity and finances, and we've got to therefore prioritize effectively and efficiently. That is a balance between prioritizing at a national level, but also prioritizing at a local level. And you clearly need to manage the political and public pressures that arise when you do start to choose priorities. The NHS has always faced this problem of effectively of political and indeed you might argue NHS service leaders not wanting to be public about the choices that have been made because they know that as soon as they make those choices public, people will jump on them. But the reality is that we simply can't do everything. Clearly, the finances are really important, and we're assuming that in November, December, there will be a 3-year spending review that sets the financial envelope for the rest of the Parliament. there is a very difficult outlook for public expenditure. And on the right-hand side, I've put a quote down there from Paul Johnson, who is the director of the Institute of Fiscal Studies, who commented after the budget that was commenting on the fact there are £17 billion of spending cuts, and particularly in the non-protected departments. And again, there's a good Anita slide on this. But actually, if you kind of look about how likely it is that we are going to be able to realise those spending cuts. And the assumption, by the way, was the protected departments have broadly got the pre-COVID budget, which clearly for the NHS is not going to be sufficient. Then the reality is that the current trajectory that's been set out, Paul Johnson was saying he'd offer 10 to 1 against that actually being delivered. And that, I think, is a real sense of how difficult the public expenditure outlook might be. So it's vital that the priorities that we go for are aligned with the financial envelope available, and that we do avoid that inevitable tendency to ask the NHS to do a lot more than the money allows. Final slide. So I think it's pretty clear, we've been saying this for quite a long time now, that one approach is to try and run faster and faster and faster on the existing hamster wheel. I think our view is that that is simply not going to work. And it's pretty clear to us that we can't deliver what's needed without rapid innovation and transformation. So the obvious question is, can the NHS innovate and transform at a sufficient pace to meet these challenges? Clearly, one of the issues is going to be, and technology clearly has to be a significant driver here. That's what's driven transformation and improvement in most other sectors of the economy. The issue is the funding going to be available, again, at a point when we've got a real squeeze on public expenditure. And just to make the point that a lot of that expenditure is capital, but we've effectively already promised significant amounts of capital for example, 40 new hospitals. So you can see pretty clearly there's going to be a squeeze on kind of capital. But it's also not just the money, it's actually about supporting organisations to make that transformation. I do think the final bit really is the culture and the operating model, which is we do need to harness that can-do spirit from the last 12 months. And in a sense, the way we ran the NHS, which was, I would argue, heading towards quite a different operating model, which is effectively being very tightly defining what national does, and effectively trying to move away from this look over the shoulder, very, very top-down command and control oversight culture to something where we can kind of empower local leaders and clinicians, get past that ICS governance set up quite quickly. In other words, get them set up as fast as we can, and then effectively really get placed and provide a collaborative led transformation going as quickly as possible. Those seem to me to be the 4 things that we would need to do to meet those challenges. So, Richard, I think I'm about a minute over, but I hope that's been a helpful tour d'horizon.
Merci, Chris. It's been fantastic and very impressively to time. So fantastic. And I'm sure there's going to be loads of questions from that. We'll lose the slides now, but thank you for that. And we've got about 10 minutes or so before Anita. I'm just going to come in on the last slide. I was going to ask you about innovation and transformation anyway, and I suppose I would ask this from an HSM perspective. Are we really up for radical transformation and innovation? I take your points about the funding. I absolutely agree. We don't understand or even respect the kind of capacity and capabilities needed to do this. But I think my challenge, to the provider sector is the culture of change and innovation. Technology is not the issue here in terms of invention. Radical exists out there. There are 1,000 different ways we could radically change the way we deliver services. From a provider leadership, are we genuinely up for real radical change?
Well, I think we will have to. We will have to be, because it's the only way to get through this. But look, Richard, I think you probably know I've had a career where I've effectively career hopped. I've been, in the private sector, in the TV industry. I then went to HMRC, and I've now come over to the NHS. My observation would be that it's quite easy to beat frontline leaders over the head about the fact that they're being insufficiently rapidly transformative. But when I think back to my last gig at HMRC, where we actually led led government in terms of some of the transformation we did in terms of moving to online services. The observation I would make, the difference between the two is the degree of day-to-day operational pressure that NHS frontline leaders are under. We've got that capacity demand mismatch. You're having to run at 120 miles an hour in order to just keep your head above water on the day-to-day operational stuff. Now, when I go back to HMRC, we were running at 70 miles an hour to kind of keep up with the the day-to-day operational stuff, but there was enough headspace to do incredible things like introduce self-assessment online, which was absolutely transformative. We were in HMRC, we were rekeying every single self-assessment form, rather than, whereas now you file it online and there's there's now, I think, 60,000 less people in HMRC compared to when I kind of joined. And this is quite a long time ago, basically because of that transformation. But we were only able to do it because we had the space to be able to do it. So I think one of the really big questions for the NHS is how do we do that transformation and at the same time cope with that degree of kind of operational pressure that we're under and try to get kind of more on top of that capacity demand mismatch. I think there is enthusiasm to do it. I think people are up for it, but they need the headspace and and the time to be able to do it.
No, I agree completely about the headspace piece, and it's good to know that you feel that people have got that people are up for it. I mean, my take on this is that as a system, we put about £1.2 billion a year into research, which is fabulous, obviously, through the NIHR, but we're only putting a fraction of that into the spread and adoption of innovation activity. And we're not going to be able to translate at the speed that we need to meet the challenges that Chris has outlined, unless we have a radical rethink of the kind of budgets that will be needed if we're going to take this seriously, the headroom that Chris is talking about. Brilliant. Questions, please. Carl, could I call on you, please? Carl Bridge, to ask your question. Carl frantically looking for the mute button. No? Okay, Carl, if you're here, give me a shout on the text and we'll bring you in a second. In that case, Chris, I'm going to take the prerogative of asking my second question. So just thinking about, I asked Sally, one of Sally's points was around a 15 to 20 year horizon of the reality of how a community will bounce back from a disaster such as this. And that, I think, was a kind of an optimistic kind of projection. You talked about 3 to 5 years minimum for the backlog. I suppose it's a political question, but do we think that's where government are in their understanding of this? And if not, are we just setting ourselves up for a 3 to 5 year punching match, I guess, between the service and government in terms of expectation management?
Yeah, I think our sense is the government is on a journey here. Certainly, even as recently as a month and a half ago, we were being told that you've had your non-recurrent billion for 21-22 to do the elective recovery. What's the problem? And I think there is now a growing recognition of the fact that the problem is kind of significantly greater than that. What happens, though, as you well know, Richard, is kind of pure raw politics kind of jumps in here. And, we run our government, having been, a spad on the inside and also been a civil servant, is you tend to run governments on parliamentary cycles. So it's really pretty clear that this government will be desperate to go into the next general election, having A, delivered its manifesto commitments, but also B, not having a very, very big waiting list kind of hanging over it. And for me, the next 4, 5, 6 months in terms of the work that we do and the work that the department and NHS England do in this space is basically about the fashioning of a deal where effectively we get access to more money and we then sign up to some sense of how quickly we will get through that care backlog whilst delivering all of the other priorities. In the media work we did over the weekend, one of the observations I was making is that I was very struck by how many chief execs were saying to us, it felt like we were in danger of going back to the early 2000s. And in a sense, if you look back at that, there were two features of those early 2000s. And we all remember, don't we, those of us who sort of were watching the NHS at that point, we did some extraordinary things in terms of, completely transforming the kind of waiting list, and actually a once in a generation extraordinary amount of work. But there were two things that we were able to do then. The first was we had 5 years of 7% plus real terms NHS funding increases. The current where we're at is 3.3. And secondly, there was a ruthless focus on effectively, elective waiting lists. And that is what, okay, there was some other stuff as well, but it was basically very strongly focused on that. And unfortunately, neither of those two things are going to be in place now. We cannot afford to just focus on the elective waiting list. We've got a whole bunch of other things we've got to do. And also, secondly, the money isn't going to be as generous. So that's the reason as to why I think there's going to be really quite an interesting debate that needs to take place about how much money can we get, how far does it go across all those priorities I outlined, and then in return, kind of what can the NHS give? But let's be really clear, Ben Page will tell you this from Ipsos Mori, is it doesn't take very many people waiting in pain on a waiting list and talking to all of their friends for the opinion of the NHS to really start dropping quite quickly. And again, we saw that in the late 90s and the early 2000s. So there is quite a difficult kind of conundrum here. And that's why we're saying the answer is we've got to have a bold and transformative approach. The idea that we just do another waiting list initiative with a bit of overtime, lots of overtime and lots of effective use of the private sector, I don't think that's going to work. It's not going to get through that quick enough. So that's why I think, the transformation in this particular area will be completely essential.
Yeah, I completely agree with that. And I'd add not just the bold and transformational approach, but a better national dialogue with our citizens.
Yeah,
I think we have to take them with us on this, and they will see the way that services are offered to them look different. And that means that we have to take them on that journey from the get-go and have them involved in that co-production of it as well. One final question from me. Obviously the theme for today is about health inequalities, and that's the thread that's running through. I'm really curious how from a provider lens, from the seats of providers, how do providers enter the health inequalities challenge? Is it for them something that's happening out there in a population health type sense, or is it felt more keenly within the walls of a provider or a hospital, Chris, do you think?
Well, I think, you need to, when we talk about the 215, we need to be careful about sort of talking in a generic way, because people are at different points on this journey. But if you look about where they are on the journey, the vast bulk, I would say, are in the foothills. We've only really just started. I think there's a lot of work that kind of needs to go on to help people kind of understand the practical things that they can do in order to make a difference here. And also to build board understanding. We're, as you know, we're an organisation that focuses on boards, because in the end, the board and foundation trust, the trust and foundation trust model is the board oversees and assures what goes on. So if you can't convince the board, it probably ain't going to happen. But there are some really pretty clear immediate things that you could do straight away. One of them would be, and there's been some really interesting work that you probably know about, that Owen Williams has been doing in his trust at Calderdale and Huddersfield, of effectively, and in West Yorkshire as well, about more broadly about cutting the elective waiting lists by health inequality data. And it shows you some pretty shocking things. That, for example, that people in the lowest 2 deciles of deprivation and people from BAME communities are having to wait quite a lot longer on the elective waiting list. So that's a really good and simple challenge, isn't it? It feels to me, to say to everybody who's got an elective waiting list, have you got the data to be able to cut it by kind of health inequality data, and then effectively what can you do to then speed it up. And just to end, Richard, on a note of kind of optimism, lovely story in HSJ today about effectively 3 trusts in Salisbury, Swindon and Bath, who effectively are really determined to really go after their elective waiting list on children and young people. And what they're now doing, because they're in their ICS and they're working as a really effective provider collaborative, is you've got patients who normally would go to Bath that's a bit full on this stuff to go to Salisbury, and then the guys in Swindon are actually putting some people over to Bath, and the guys at Bath are putting, so effectively there is, and they are now going to get through that elective waiting list for their children much, much faster than had they not collaborated. And that for me is a really great example of what you can do. So yes, of course, we need to have the debate about who's the one provider representative on the ICS NHS body board. That's, yes, important, because that's going to allocate the money. But look, in the end, that's what it's all about. It's actually about, can we speed up and get better quality patient care by using collaboration across a system footprint to make it work more effectively. So the more that we can do of that, then I think the more we will be able to address some of these issues.
Wonderful. Thank you, Chris. Great note to end on. Thank you so much for that. We're going to move on to our last speaker of the day, Anita Charlesworth. Anita is the Director of Research and Economics at the Health Foundation. You will all know Anita very well, I'm sure, and she has been, like Chris, a regular on this event for the last 6 years. As well as being Director at the Health Foundation, Anita is the honorary Professor in the College of Social Sciences at the HMSC at the University of Birmingham. Now, I'm told that Anita has the ability to make even the gloomiest predictions for the outlook for public services sound as if there may be possibilities and opportunities ahead. So it sounds like the right speaker to have as our last bit of content here. Again, as always, there's time for questions following Anita's presentation, so please do use the chat box. Anita, welcome. Lovely to have you here, and I will hand over to you.
Thank you very much. And I think my slides are due to just come up, aren't they? Fingers crossed. So what I'm really going to do, that's a very nice photo. It is put some numbers around some of the things that we've been talking about so far, but I will need some slides up. If there's a problem with doing them centrally, I could screen share from my, here we go. Can I go to the first slide then, please? And I thought what I'd do, I'm taking a medium to longer term perspective about where we sit. And what I wanted to do was to start with, what are some of the big issues then that across health and care systems we were facing before COVID, and then also just to reflect on, well, what does the recovery phase after COVID look like in relation to that? And I've used some of the thinking that the OECD has been doing around healthcare systems to think about this really in 3 categories. And I think there's an incredible amount of detail, and I'm going to give quite a lot of detail as well. But if I'd like you to go home having taken one message away, I think it is in all that you're doing in the short term, which will feel incredibly pressurized, to try to think within that, are there ways of doing that that helps in the medium to long term in these 3 buckets or circles in my case? The extent to which our system is addressing some of the equity challenges that we face, the extent to which in our system we're not just delivering today, but building greater resilience, and the extent to which in our system we are looking to ensure that it's sustainable, because it's no good to people if we have a fantastic health and care system today, but actually in 5 years' time it's gone. And so in terms of those 3 aspects of a really well-functioning health and care system, what do I mean by that? Well, under the equity one, I've highlighted 4 things which I think are our high-level challenges. Obviously, big question which Richard alluded to a number of times in his presentation and in subsequent conversations about the huge health inequalities that we face in our society, and the role of care systems, both directly in that and then as partners with other parts of social infrastructure to tackling that. The second question is inequalities in access. And as Chris was mentioning in relation to waiting times, but we see it across the service, we've done work in GPs where a GP in a deprived area is looking after many more patients than when you adjust for need than a GP in an affluent area, still 70 years into the NHS. Other inequalities in access are big differences in access between physical and mental health that we've seen. The third issue, and I've said it as it is here, I've used the word because I think it's really important that we own this word in our systems, is racism and the issues which staff face and the issues which patients and service users or potential service users who would benefit from our system but can't find their way in face, which we obviously very important through the pandemic have begun to think about really seriously, but at the foothills of the journey on that one. And then the fourth issue, I think, is the inequity between social care and healthcare. And that's not just a funding inequity, important though that is, I'm going to talk quite a bit about that, but also actually, you know, very different standards of care as well. So those four issues seem really, they were really important before COVID. They're even more important now. On the resilience question, you know, we know shortages are endemic in our health and care system. Workforce is the most important, lack of capacity on any measure that we can pick, really, beds, ICU, community provision, diagnostics. Our public health infrastructure we've run down. I think hopefully realise the folly of that. We need to rebuild that. Another thing of resilience, which I wouldn't have talked about 18 months ago, but is really important, we've obviously seen, is our approach to supply chains and how we build resilience there. On the sustainability point, the criticality of productivity growth, as Chris was saying, and really thinking carefully about where that's going to come from. Really important issues in the fragility of the provider market in adult social care. COVID is one type of health emergency. It's one that's in your face and you can't avoid. There are other types of health emergency that are less visible, but no less important. And the environmental issues are top of the list there, and the move to net zero and the NHS and care system thinking about both how it mitigates the effect of climate change, but also how it contributes to be part of the solution to reduce pressures. And then the big one, which I guess the bill is trying to think about and the long-term plan is very focused on, is how do we change our model of care to meet the changing health needs of a different population, ageing population with chronic disease and multi-morbidity, which has not gone away and is still there. So a huge agenda pre-COVID. When I look at that agenda in terms of the medium to long term, I don't see COVID really changing that agenda. What it does, I think, is amplifies that and emphasises certain areas. And I guess overall, my sense of this is very much Chris's sense of this. It's the scale and the breadth of the challenge that really hits home when you look at this. So next slide, please. So just a couple of things then to emphasise on that. Before COVID, I guess the long-term plan was starting to address some of these issues and had a funding settlement which for anyone outside of the NHS looks generous, 20-odd billion pounds in real terms, 33 billion pounds in cash terms, funding growth of over 3% a year. Quite a lot of that ring-fenced for primary care, community care and mental health. So I like to do these figures after adjusting for inflation. So I've got 20 billion pounds going in essentially over this period 18-19 to 23-24. I've got over 6 billion of that, or almost a third of that, ring-fenced for primary and community and mental health. Some of that, about nearly 5 billion, 4.7 as you've seen, to try to sort out the waiting times and stabilise trust finances. Yeah, looking really then at around 8 billion left for acute and specialised services. So this going into COVID was how the NHS was hoping to deploy its funding. So growth in the NHS, growth above inflation, growth actually above economic activity, a desire here finally to really protect resources to invest in mental health and primary care, get our system stabilised in terms of finances and waiting times. Yeah, but next slide, please. But that actually did hide quite a tough challenge already, and I think it's important to recognise then that COVID's on top of really ambitious plan for this. So with that desire to ring fence money for mental health and primary care and community, which by the way I support, and to stabilise our system, what that meant actually when you backed out pressures in the system was there was money for activity to grow, this is my red bar, by just over 2% a year in the acute and specialist areas. But if we look back then over recent years, that's much lower than activity growth going into this period. So within the long-term plan, there was embedded within that an assumption that we could significantly change demand and change pathways of care. Yeah? And actually not that much detail about how we were going to do that over what is a comparatively short period of time, and a history where we've had that as our objective for a very long time and really struggled to deliver that. So next slide, please. The other thing, just to put some data around this issue around health inequalities. So this is life expectancy and healthy life expectancy at birth in England. And the top line is the most deprived 10% of the country. And what you see there is life expectancy at 74, but really do focus then on the healthy life expectancy, just 52. So 18 years of life in ill health. Yeah. Contrast that with the most deprived 10% at the bottom. Not only is life expectancy much longer, 83, but the period of life in ill health is much shorter. But as an economist, when I look at this, what I also look at is what's the age of retirement in England and what's the age of retirement planned to be, and it's moving rapidly to 67 and then up to 68. And we've got lots of our population with a healthy life expectancy way below retirement age, struggling then either to work through ill health or to not be able to work, be then suffering the consequences of that through their middle years and not being able to provide for income into retirement. Yeah? So this is a health issue, but also it's a real issue, I think, for vibrant communities and for poverty risk in those communities, where you get into a vicious cycle, you know, of ill health, low income, ill health. And so I think this is a really important issue. On the next slide, if I then look at women, yeah, then actually the gap in terms for poor women in terms of long years of ill health towards the end of their life is really, really stark. And if we look at women under 50, then actually life expectancy has been declining in deprived communities, not increasing. So this does feel like the number one issue that we need to be focused on. And as we move to these new structures and place-based thinking about health and care, this absolutely needs to be front and centre of everyone's agenda. Next slide, please. And then on the capacity front, just to emphasise that point, I could put any measure I wanted to on here, and the UK would be in the bottom quadrant, which is below average compared to OECD countries. In this case, I've put doctors per thousand and hospital beds per thousand, and you see in both we're low. You actually see as well immense variation between countries, but we're low on every measure that we can think of. Yeah, next slide, please. And we went into this crisis, lots of people in their talks, and Sally very powerfully highlighted this in her talk, which I thought was so important on how you do recovery, and the impact that all this experience has had on staff and how central their well-being is going to be alongside community well-being. One of the things, again, I want to say is that COVID happened in a context, and I think that's really important to think through as well. And that context was that we have been running our system exceptionally hot for a number of years. So in this slide, what I've looked at is the full-time equivalent nursing growth in the NHS between 2010, 11 and 17 against activity growth. And so over that just under a decade, the NHS delivered almost 30% more activity, patients cared for, with basically the same number of nurses. So that's an incredible, in a economics term, that's an amazing productivity improvement. But actually, is it a sustainable one? We've pushed staff unbelievably hard before COVID. They went into COVID already feeling then like they were working at or beyond their capacity limits. And then they've managed an incredible health crisis. So we can't simply go back, and we need to recognise that this exceptional period happened on top of a sustained period of high workload, real worries about whether or not you could deliver a high quality job in that context. Next slide, please. And we'd also seen then that actually NHS pay had not kept pace with inflation, and actually had not kept pace with other, across the economy, other earnings. And we did a calculation. So in essence, NHS earnings fell by 2% over the last decade, which is our calculation. Depending on when you start this, you can make the number look much bigger as well. But under any start date and end date, it fell. That is worth around £600 per employee. And whilst in the early phases of the decade, coming out of the Great Recession, it was a bad time for all workers. Actually, in other sectors of the economy, earnings growth did then pick up faster than in the NHS. So also our pay has become less competitive. And that's another factor that predated this, but is important, I think, in that context. Next slide, please. There was also, I think, Chris mentioned about social care. We did some work for the Health and Social Care Select Committee, looking at not the deal knot type ideas about, the fair funding between the individual and the state, but the other pressures on the social care system. And we did, what's that, 1, 2, 3, 4, 5, 6, 7 different kind of combinations of things that you might want to fix to look at the numbers. So the most minimal one is, that you're going to have more people next year who are falling into the needs and the means test for social care. What does that look like? It's a funding pressure of around 2 billion a year out to 23, 24. So keep the system exactly as it is, but recognise that there are some more people who'll be eligible. What's that look like? 2 billion. 2 billion minimum. But we know we've got issues around pay, and in particular pay not keeping pace elsewhere. If you wanted to do something about that, will you double that amount to about 4 billion? Access to care has really reduced compared to where we were in 10-11, and the amount of funding we provide to providers in order to deliver a quality service. Get back to that, and you're talking about 10 billion. Get back to that and recognise that that wasn't nirvana, and pay was already problematic. At the turn of the decade, you're talking 12 billion. So you can't get away with less than 2 billion. You could very easily get up to 12 billion. And the select committee rightly said to us, well, 12 billion is really big number, which it is. How about somewhere in between? You know, you try and improve some of the provision, address some of the issues around funding packages not meeting minimum quality standards. What do you get to? And we said the last one, G in my figure there, about 7 billion. To give you a sense of the context of that, you put 1p on the standard rate of income tax and it raises about £5 billion. Yeah, so it's big numbers as well against a context in which the baseline level funding for adult social care is about 20 billion. So whichever way you look, social care needs a major injection of funding. Next slide, please. Yeah, and if you did want to do something about the DILNOT cap, and you set that cap at about £46,000, you're adding on another 3 billion. More generous than that, you're talking about 4.6 billion, and something that is akin to free personal care, you're talking 8 billion. So there isn't a tweak social care funding options. This feels pretty existential to me. Prime Minister has restated the commitment to sort this and to produce a plan for this year. But it's going to be really difficult, I think, for the government. And I'm going to explain why it's so difficult in just a second. Next slide, please. The reason why it's going to be so difficult is because COVID has been a health crisis, but also an economic crisis. And if you look at this, and hopefully with the vaccine rollout, we'll bounce back more quickly, but certainly alongside being very hard hit in terms of deaths, we've also been very hard hit in terms of the GDP loss. At the peak, down 20%. At the turn of the year, I think the OBR was saying economy 10% smaller than it was going into the crisis. Yeah? So some of this recovered, but still £1 in every 10 of our national income gone. Yeah. So next slide, please. The upshot of the health crisis requiring a huge amount of spending and the economic crisis impacting on receipts is we're borrowing a shed load of money. And the red line is the latest estimate on that. So in 2020-21, we're borrowing £350 billion. £350 billion. The Chancellor wants to get that, and that's 17% of our national income. Chancellor wants to get that down fast. So this is kind of history repeating itself. You think in 2008, we were borrowing a huge amount of money and the government wanted to get back into something close to balance fast. Well, it's doing exactly the same here. So he wants to get that borrowing down to just under 3% of GDP over 5 years. He's announced some tax cuts, but that's a huge, huge consolidation. Next slide, please. Now, obviously, a lot of that is the result of the COVID spending, and quite a bit of that will be temporary, you know. So there is the support to households, the support to health service at 85 billion for health, totaling 85 billion, support for other public services at 72, support for businesses. Yeah. Some of that health spending as well, very temporary. PPE costs were much higher, obviously, while we were sourcing it temporary. But also, you know, as Chris has said, we're going to be running a vaccine for years. We think we're going to be running some form of test and trace for years as COVID becomes endemic. We're almost certainly going to have elevated infection control requirements, which again will have an impact. So while some of this is short term, there are also real questions about how realistic it is to think that all of this goes away and goes down to zero. I don't think any of us in the system think that that is tenable over the next 5 years. Who knows after for 10. Next slide, please. So he is expecting, unfortunately, that public spending will have to bear some of the brunt. Again, if this feels like deja vu, it really does feel like deja vu to me as well, back to early 2010s. So he announced in the budget, a further squeeze on day-to-day spending out to 24-25. Yeah, next slide, please. So what that means in real terms, just then put some sense in this. So if I take spending in 9-10, this is Resolution Foundation, brilliant analysis, take spending on public services, day-to-day public services in 2010, that's the 100 line. Yeah, and RDEL is the jargon for day-to-day spending on public services across government. Yeah, and health is what's called a protected department, as is education and a bit of overseas development, where there are long-term commitments that the government said it will hold to for real increases. And in those services, obviously, by 1920, they were sort of just about back to where they were, yeah. But spending will be 10% higher in 24-25. This plan that the government essentially announced in the budget will mean, once again, though, when you think about unprotected departments, which are things like local government, transport, criminal justice system, that they face ongoing austerity. And in 24-25, spending on those areas will be a quarter lower per head of population than it was back in 2009-10. But it isn't just the NHS and social care system that will face growing pressures as a result of COVID. You know, if you think about transport, you know, it's clear that public transport will need ongoing support. We've got huge backlogs of cases in the courts. We've got real issues, obviously, across local government, community resilience as well, lack of youth services, all of those issues. So, I mean, this looks very, very difficult. And I think Paul Johnson's point, can this really hold? But what on earth would it mean if it did hold? It is really important to think through, especially when you think back to what Sally was talking about the importance of community resilience. So there's not going to be a lot of financial support to build that resilience unless something changes between now and the autumn. Next slide, please. In the NHS then, how does COVID change the funding picture? At the moment, the government's committed to meeting the short-term funding needs on COVID, but has got nothing budgeted beyond the long-term plan figures after next year. So we've had a look at what some of those areas might be, and in the summer, I'm doing more work on this, try and bottom it out in a bit more detail, ready for the spending review. But just looking at that and thinking about what some of the domains, that does not look realistic. Can we have next slide, please? Yeah. So one of the big issues here is that because of COVID, although we've seen lots of productivity gains as we've moved to digital, you know, we cannot run our hospitals in the way that we used to run them. And inevitably, that impacts throughput. And if that is short term, yeah, then that's sort of fine. But actually, if all the new infection control standards are going to stay with us in some form, yeah, actually, it's going to be very hard with the same capacity in terms of people, beds and equipment to get the sort of levels of activity that we used to see, and we will take a productivity hit. And a productivity hit drives big spending numbers. Yeah, and I can put productivity hits in, which are very plausible, which have a huge impact on the amount the NHS needs in funding terms to deliver the activity that is required to meet health need. So that's a really critical issue that will determine either how much money the NHS needs or the standards of care that we can provide. Next slide, please. And when you add on to that, if this is the modelling work that was done for the roadmap out of lockdown. And all of that work is saying that actually activity pressures on emergency will increase long term, because we expect COVID not to go away, but to become endemic. at a lower level. Essentially, I guess the way I find it easiest to think about this is like a really bad winter. Yeah. And so if we're going to factor that in, we're going to potentially have lower productivity because of all the infection control standards and the way we need to work, and higher demand on the emergency side, at least in winter, as we manage waves. And we may also see not only that happening, playing out nationally, but local outbreaks that need to be managed. Yeah. Next slide, please. We've also then got this backlog in care. And I find this the easiest way to understand the backlog. So in 2019, this is the amount of completed care in the elective pathway that we did in the NHS. That's the red line. And the blue line is what happened in 2020. And basically the size of your backlog depends on how much of the gap between those two lines you think will reappear. And do you think there's a whole load of health need out there that has not come forward, but needs to come forward, yeah, if we're to ensure that people have good, healthy lives? Or do you think some of this was fairly ephemeral and won't appear again? And no one really knows the answer to that. We've assumed in our work that about 75% of that comes back. Yeah. Next slide, please. The impact of that is that we've got very lengthening, obviously long waits, and the 52-week plus is at over 300,000 now, compared to less than 2,000 pre-COVID. Yeah. Next slide, please. But I think it's not just the numbers. What we're also seeing when we dig into the detail is, unsurprisingly, probably the backlog will require more work than a typical flow on, because the backlog is greatest in the specialties and the services that require inpatient admissions. So if you look at dermatology, where a lot of it can be done remotely now, yeah, actually the activity has got back pretty quickly. If you take trauma and orthopedics, which is hips and knees and all of that, yeah, we're still a long way below, and the backlog is biggest there. So actually dealing with the backlog is probably going to need quite a lot more inpatient care than your average year of activity. Next slide, please. But also we're seeing, as Chris alluded to, with the work of Owen Williams and others looking at their lists across the country, that actually this is affecting deprived communities greatest. So the gap in care provided and the gap now is greatest in the most deprived CCGs. So I think as we think about waiting list management and dealing with the backlog going forward, I really want to strongly endorse what Chris said. We need to have an equity lens on this everywhere, very significantly. Next slide, please. So, looking at that sort of picture, the amount of activity that we're going to need to do is huge. We reckon it will take 5 to 6 years to get back down to 18 weeks with at least £1 billion a year dedicated to that. I'm remodeling that. I'm sure I can get bigger numbers. There's huge uncertainty depending on how much of that backlog appears, and also how far we can get back to those sort of normal levels of productivity, and the extent to which we can then ramp up in reality with private sector and overtime, or really thinking radically and reimagining the way we deliver care. Yeah, next slide, please. But alongside that, as everyone said, we've got rising demand for mental health care. We did some modelling with the strategy unit in the West Midlands on this, estimating the new referrals, very significant numbers. This was before this winter lockdown. I think, again, those numbers will have gone up. Next slide, please. And The other thing that I think is a real issue around the funding is we've got these new pressures, the backlog, endemic COVID. I haven't talked about long COVID, but all of those issues, mental health as well. But also in the NHS's funding settlement, before this happened, there was a settlement for NHS England, but actually no settlement for capital, public health, or the workforce. As I think I alluded to, we went into this with really big workforce shortages, highly concentrated in nursing in particular. COVID has exacerbated all of that. We need to retain, we need to increase our capacity. Although we are quite reliant on international recruitment, it remains the case that the most important source of nurses in this country are the numbers that we generate through our own recruitment. So that's 61%. So next slide, please. Yeah, almost done. Actually, the number of people wanting to work in nursing has gone up, but we need to fund that, not just this year, but on an ongoing basis. So that's a new pressure that the Treasury will need to address. Next slide, please. We're also below on capital and need to put that capacity in place. That at the moment, there's this 40 hospital plan, but no actual long-term capital funding plan. That needs to be put in place. Next slide, please. And the public health grant has gone down in real terms and will require significant additional investment to restore and ensure that we are it is able both to be resilient for pandemic or other health shocks, but also tackle some of those underlying issues that lead to that healthy life expectancy gap. Next slide, please. So in conclusion, the fundamental long-term issues facing the NHS actually are largely the same, but the scale is huge. Real issues about where the money is going to come from in order to tackle such a wide range of issues, but also leadership capacity. Can the system deliver across the board, especially with a backdrop of further structural change? But we almost certainly can't afford not to. So how do we prioritise and what support do we provide? Thanks.
Anita, thanks so much for that. That was illuminating and sobering, I think, is what I'm taking away from that. And I mean, compliments us that what we heard from Chris, I think, so brilliantly and perfectly. So thank you so much. I know as an economist, you probably don't like to speculate too much, but I guess my question to you is just going to be, given all that, and as you said a few times, if, and I appreciate it is an if the spending plans hold, what do you think, what's the most likely headlines we'll be seeing about the NHS in 5 years' time, do you think, Anita? I mean, where do you think we'll be as a result of the variables that you just flagged to us today?
I mean, I think it's really serious because, support for the service is rock solid, yeah. But actually, we should not be complacent about that. We've just had a look back at 20 years ago when the NHS got its last funding injection and going into that. And lots of very serious institutions, including BMA and others, were questioning whether or not the current model was sustainable because of the issues that people saw, where they supported the principle, but at the funding levels that were provided and a prolonged period of underfunding and mismatch, actually people saw that it was threadbare and wanted something better and couldn't see a route through public spending to get there. So we should not take that current support for granted.
Yeah. Thank you. Timothy Crowley's put a very good question here, particularly because it's Stephen Lawrence Day today. I do want to just bring reference to this. So Anita, you talked about your opening slide about racism being a barrier to equity, which Timothy agrees with. Goes on to talk about the recent government report, which Lee said better, I think. But how, as boards, can we deal with this? And I think obviously a question for you, Anita, but I think also it's a question for all of us here. So I think if people have contributions to make, I would love to see some more comments in the chat about this one. Any reflections, Anita?
Well, I mean, I guess I'd reflect on a couple of things. I think If we're going to be creating new organisations, then we really do need to think about ensuring that we have diversity inclusion at the heart of the recruitment policies for those new boards. You know, it is not acceptable in 2021 to have the leadership of our new system, which we're putting in place next year, not reflecting the communities that they serve. Absolutely got to be non-negotiable, that one. Yeah. And then the second thing I think is I hope those new bodies, and what we're seeing very excitingly is the NHS becomes an outward-looking sector, which embraces some of the anchors institutions agenda and thinks really deeply and hard about its connection into communities, that health happens in a social and economic context. And that's important for delivery, it's important for staffing, and it's important for leadership. And that has got to be at the heart of our culture, it seems to me, and infuse all that we do. And if you sit on a board and these issues are not front and centre of your board papers, your discussions and your agendas, look hard at yourselves.
Thank you for that. And we're coming to the end, obviously, of the Q&A. So, Chris, thank you for joining us again. Chris, if you don't mind, I'm just going to throw that same question to you as well from Timothy about racism on boards.
Yeah, and I think the way the question was framed, I think, is a particularly important one in terms of that recent government report. And hopefully some of you will have seen that we've come out really clearly and said that we just disagree with the report. And we thought it was unfortunate. There was a lot of really good data in there, and there was some really interesting kind of focuses, but we thought that it was really unhelpful to effectively argue that structural or inherent racism, there are a number of different phrases for it, are not an issue, because that is so clearly the lived experience of those who are on the end of that racism. And we know from the Workforce Race Equality Standard data that we have a real problem around this in the NHS. And I know that the government and those who wrote the report were basically trying to dismiss people who were disagreeing with it as sort of the race relations industry or the woke brigade. It's just not right, and it's not appropriate. And it really did feel very uncomfortable to us, which is why we were... Every so often, we have the opportunity to be very forthright about these things. And that's exactly why we chose to be forthright on that issue. And what I would then basically say is, I think, Anita, yes, you're absolutely kind of spot on in terms of boards need to take appropriate responsibility for this. We know that it's not easy. The data is really, really important, but it's only a part of it. And just one final point is that I do think, I mean, racism is absolutely kind of fundamental, and race as a protected characteristic is really important. But we just need to also recognize that there are other protected characteristics that absolutely we need to think about. And there are broader health inequalities, which are often, you know, they're intersectional, they often kind of relate. So disability and deprivation, there's a clear link. Race and deprivation, there's a clear link. But there is a broader kind of set of activity we need to undertake here, not just focusing on race equality issues if we want to tackle health inequalities. But I do think it's really important, as I said, that people should, and I think there are some really good examples of this over the last year, of trust leaders. One thing they absolutely can do, two things they can do, is first, they can absolutely openly acknowledge that there is a real problem around structural racism. And secondly, they really, you know, they can really, and we know this has been incredibly helpful in lots of places, is they can absolutely listen carefully to the lived experience of those who are on the end of that structural racism.
Thanks, Chris. Very, very well put. And thank you for being forthright on the report. It was almost a Super League type of response, I think, from the government heard loud and clear. Only a few minutes left, and just to give our panelists a heads up in case I've not seen it on the notes, we're going to conclude with just 3 reflections from you each in terms of your thinking and your what you've heard today. So just to give you a heads up on that, we'll come to that in a few minutes. Before then, Amanda McGlennon, I think you're still on the line. I wonder if you're happy to just give us your question again on system working that you posted about half an hour ago. So Amanda, are you there?
Let me just unmute myself. Let me find my question again, sorry. It was, I mean, I think it was really about the thing that everybody's been talking about. And I've worked in both health and social care over the past 5 to 10 years as a commissioner and working within transformation. And I guess it is to support the shift away from acute and to community-based care, and to continue to support admission avoidance, and, you know, really kind of to work on that preventative agenda as well. Do you think it is achievable with the continuing lack of clarity on social care reform and the capacity, demand and workforce tensions within social care, especially as well?
Well, I mean, Sally's really well networked in on social care reform. I guess I'm a kind of glass half full person in that I think if not now on social care reform, then never. I mean, you know, surely this pandemic has shone a light on the absolute importance of that. I guess if I am a bit pessimistic, it is that the pressures on the government are so, you know, history is not on our side, you know. There are many times when I've expected finally this must be the moment, and it's not worked. The money to sort is huge, you know, and it's and reform is complex and about a lot more than the money as well. So there are so many opportunities for government to walk away. I guess to put it more back in our hands, I think it's easier for them to walk away if they feel no pressure. So I guess the thing for us all to say is one, to make sure they feel the pressure, but also to unite around some solutions, because it's easier to walk away and more tempting to walk away if the sector is not united, you know, because then it's very difficult to reform where a sector is not coherent in its ask.
Thanks, Anita. Chris, any thoughts on the social care?
Unmute. Well, I did a podcast with Jeremy Hunt this week where effectively we were talking about this, and I said, is it going to really happen this time, Jeremy? I mean, you know, Prime Minister after Prime Minister has promised that this is going to happen, and, you know, Boris has sort of indicated that he kind of might, you know, he's sort of hinting it might happen in the Queen's speech, but interestingly, he was rather less definitive than I was hoping for. I mean, to be fair, that it is complex as I set out. It is politically kind of difficult, but I don't know. It frustrates the hell out of me if no, it is a failure of our political class. It is an egregious failure of our political class to grasp this. And the whole point as to why we elect politicians is to grapple with the difficult stuff. We can all do the easy stuff. They're there to do the difficult stuff. And, you know, it just, as I said, I'm sorry. I'm just, you know, I've just lost patience, if I'm honest, Richard.
And what did Jeremy say, Chris?
He basically said that he hoped, but he wasn't. He hoped it would happen this time, but I don't think he didn't quite say he didn't say he wasn't holding his breath, but it was less definitive. I mean, you know, I was hoping he was going to say, well, yeah, you know, this is definitely going to happen. But, you know, he had a go at Boris when he did the last liaison committee. And to be fair to Jeremy, I mean, he did have a really good go at it. I know, because I was talking to him about it at the time, and we would, you know, in the margins of what we were doing in the podcast, he was saying again, and he really did try and nail. He did try and you know, really box in Theresa May to make it happen, and he sort of got most of a good way along the track, but then Brexit intervened. So, you know, what is just unsustainable is what we're basically doing at the moment is effectively you know, each time that it looks like it's going to go over the cliff, we put just enough money in to pull it back from the edge of the cliff. It's just completely not sustainable.
Okay.
Sorry, I'm not Richard.
We have just 3 minutes left, so I'm just going to ask some very, very quick reflections from the panel, if I may, and then we'll hand over to Steve to conclude. So, Anita, just some final thoughts.
So, I think the fundamental leadership challenge here is to try to think about how to hold on to the important in an enormous tsunami of urgent. Yeah, and I wish you all good luck. But can you try whenever you can? You know, if there's a way of dealing with the short term, that has an eye to the medium, those big fundamental medium to long terms. Have it in your mind always, where, you know, if I've got a choice of 2 ways to deal with the short-term challenge, and one would help with those big fundamentals, equity, resilience, sustainability, pick that one.
Thank you. Chris?
Yeah, I think at the moment, I mean, Richard, I come away from each of these things almost every year thinking, for me, it's the personal view you take of whether the glass is half full or the glass is half empty. And I think the requirement on all of us as leaders for our staff is to make the glass as full as possible. And as I did with that slide of the risks, there are lots of good reasons as to why you might be really kind of a bit kind of, my God, look at the scale of that challenge. But the whole point, I think, about being a leader in this kind of environment is actually about being as optimistic and as effective at leading your people through a really difficult, challenging time. And I think that's actually about, as I said, a lot of that is about your own personal resilience and ability to have the glass as full as possible, even though in reality it might actually be well below half empty.
Thanks, Chris. Just a few things from me before I hand over to Steve. So I think I found it today really, really fascinating, actually. I mean, my takeaways are, we've not yet crested this peak. In fact, we're probably still in the foothills as far as the timelines are concerned, at least. Sally talked about 15 to 20 years for society to recover. Chris talked about 3 or 5 years for a backlog. Anita talked about borrowing continuing for the same kind of time frame. So there's a lot to go here, and government and even the public may get impatient with that reality. We have learned what we should have already known about in terms of health inequalities and that are prevalent in society. What we do about that, I think, is absolutely crucial. And the final thing for me is we can take comfort from those times when we have tackled challenges of this magnitude before. But it is crucial that we recognise that our toolkit for success will probably be radically different than it has been in previous eras. So those are the 3 things I'm taking away. Steve, hand over to you to finish us off, please.
Thanks, Richard. Excellent chairmanship and spot on in terms of time. So thank you for that. Right, it just leaves it to me to bring the session to a close and to thank all the speakers. So Richard, Sally, Chris, Anita, thank you again for your really insightful and thought-provoking presentations. I think it's been an excellent day and I hope everybody's really enjoyed it. And just comments, you know, we'll take away Chris's point around all having our glasses as full as possible and having a positive spin on things. If I could just ask you to complete the evaluation forms, please. This should be appearing in the chat box as I'm talking, and this will really help us in terms of planning future events. And in terms of future events, the next event is on Thursday, the 13th of May with John Amici, Leading for Inclusion. And again, the link for this will be going into the chat box shortly. So thank you, everybody, for your attendance. I hope you've enjoyed the event and we look forward to seeing you again. Thank you.